Good afternoon, and welcome to the Connecticut Society of Eye Physicians Scientific Regional CME meeting. My name is Ed Lim. I'm a Connecticut ophthalmologist and retina specialist. I will be joined by Vincent Deluise, our tireless and extraordinary host, member of our society, and driver of our educational committee. Martha Howard, our president, and the executive committee of CSEP would like to welcome you to this meeting and to thank you for spending your valuable time with us. The meeting is in two sessions. Tonight, the virtual session will kick off the event with 5 nationally recognized experts. If you look on your screen right now, you'll see that there's a scanning QR code for CME credits. If you image that QR code, it'll take you to the website. There, you can answer questions, do your evaluations, and sign on for your CME credits. Below that QR credit, there's a scan code so that you can review the full agenda. This is important because in the interest of time and keeping this so that we're hearing more of our speakers, we're going to just give abbreviated bio on our speakers, and you can read their full list of achievements on the full program. It'll also give you an opportunity to look at tomorrow's program on January 13th. At that unwired meeting at the AquaTurf in Plantsville, Connecticut, you'll have the ability to enjoy the traditional physical format that we've enjoyed for so many years, where lunch is provided and on-site sponsors, vendors, and your colleagues will be there. In addition to this physician meeting, your ophthalmic technicians will be offered CME earning credits virtually on January 13th, 2023. These CE credits are essential to them maintaining their ophthalmic certification. We encourage you to allow your technicians to sign up for the CE credits and the program. It'll help them, which will help you on your day-to-day activities. For you tonight, this session will earn you 2.5 AMA PRA Category 1 credits. Tomorrow's physical meeting will earn you 4 Category 1 credits. We hope that we'll see you all there tomorrow at the AquaTurf starting at 7:50 in the morning. Our first speaker tonight is Arsham Shabani, and he's going to speak to us about the management of malignant glaucoma, recognizing it, understanding the physiology, and discussing the rationale for treatment. Dr. Shabani completed his fellowship with Ike Ahmed and returned to Washington University School of Medicine as a faculty, where he also serves as a residency program director. He's currently involved in device design, aiming to make glaucoma surgery safer. He's also developing biomarkers for the diagnosis and monitoring of primary open-angle glaucoma and pseudoexfoliative glaucoma. Dr. Shabani, we look forward to your talk tonight. Thank you.
Thank you so much. Let me share my screen here. Okay. Are we good? Can you see it?
Yes, we can.
Okay, perfect. Sorry, it just told me it was going to log me off and I had to sign back on. So glad I can make it back. So I really appreciate the invitation. I think you have some fantastic people on the panel. This is going to be a little bit more nuanced with malignant glaucoma. And I'd like to bring this up because I do think that it has applicability to many of us that are doing cataract surgery. These are my disclosures. I do work with some of the MIGS companies involved in the glaucoma space, and they're not really relevant to today's talk. So to give you a primer on malignant glaucoma, in the BCSC, we really think of it as something that is coming with like an extremely shallow chamber, pressures in the 50s. Initially actually described by von Graefe, the man was a giant in the field with a lot of contributions. And you'll see reports in the literature that it's generally seen after incisional surgery, but in many, many different types. When you look at the glaucoma perspective of this, many times we see it post-filtration surgery, and we're trying to manage is it overfiltration or malignant glaucoma after some of the filters that we do. It can occur spontaneously in unoperated eyes. We'll talk about that. I think it's actually on a spectrum of disease with uveal effusion syndrome. Can certainly be bilateral, although it's rare. But what I want to point out is when we call it aqueous misdirection, we're really kind of missing the point and the mechanism here. And part of what I want to talk about is what is the mechanism of malignant glaucoma? Because if we understand that, we can actually turn our attention to properly treating it. If you think of the ciliary body as the site of aqueous production, and you tell me that it is producing aqueous at such a high rate that it's squirting out, then by turning that ciliary body posteriorly, it's going to squirt fluid into the posterior segment, and then all of a sudden trap fluid in that space and push everything anteriorly. I think we'd all laugh. Aqueous isn't produced that way. You know, during ultrafiltration, there's passive mechanisms and even active secretion. It is percolating out through the ciliary body. This is not like a garden hose pointed the wrong way. And in fact, when you view it that way, you start to kind of think, well, maybe the ciliary body rotating backwards isn't really the mechanism that's causing this shallowing of the anterior chamber, because again, that whole process doesn't make sense. It really is a proper term when you call it malignant glaucoma. I tell patients that are having it that they're in malignant glaucoma, but it's not a cancer. This is just going to be a really tough thing to treat, and it will be a battle. In the grand scheme of things, I do believe that it follows and involves some poor vitreous conductivity. Vitreous is mostly made of water. There is some fluid movement through the vitreous, and when it's compressed, and we'll talk about what I mean by that, then there is the chance that you get less movement of fluid through that space. You'll generally see this with eyes of shorter axial length, and this is to do with scleral permeability that we'll touch on, because the sclera is actually thicker. So they end up having more fluid that holds in the choroidal space. It does involve an anterior displacement of the lens hyaloid face, which is why we see the shallowing, although it does not have to be something that is so shallow and flat to where you have a minimal amount of space between your endothelium and this lens iris diaphragm. I do think that you need a PI. You do need to rule out a pupillary block mechanism when you have patients that you suspect malignant glaucoma, and you need to make sure that there's no massive posterior segment mechanism aside from the choroidal expansion that we'll talk about that's causing it. So not a suprachoroidal hemorrhage, not large choroidal effusions, not a mass. And it just does not have to present with a completely flat anterior chamber or severely elevated pressures, and I'll demonstrate that through cases. Traditionally, we treat with cycloplegics, glaucoma medications. I do think that you need to start here. I have one patient currently that actually we're managing with medical treatment alone on atropine, and it's enough to rotate the ciliary body back. I do worry about her over time because there's no sulcus space. There's still a chance that over time her lens can rub against the iris. And then generally the treatment can progress to a laser. You want to make a peripheral iridotomy, and you will see why we advocate going through the capsular bag and disrupting the anterior hyaloid face if you really want to break the sequela of malignant glaucoma. And then pars plana vitrectomy that really includes removal of the anterior hyaloid and still, in my mind, requires a pupillary hole that will make the entire eye one system. So I kind of think of it, treat malignant glaucoma as if you're treating angle closure for the entire eye, versus when we treat angle closure, we're doing a PI for just the anterior segment. So just a little bit about angle closure eyes, since they are at a higher likelihood of having malignant glaucoma. When you look, there are eyes that you will see, and you're looking at the anterior segment OCT images where you get these septations here in the supraciliary space. And in angle closure, the sclera is generally thicker. There's probably less fluid conductivity leaving from the choroidal space through the sclera and exiting. And so there are things that can precipitate this that can happen de novo. But in general, you'll see that angle closure eyes over normal eyes, even glaucomatous open angle glaucoma eyes, can have more fluid in the choroidal space. I like to use this case as an example. It was sent to me for a traumatic dislocated cataract. Initially, it kind of looked like that until I checked the pressure and looked at the angles. The pressure in this eye was 17. The angles are completely closed. And if you look, you see these septations on the UBM where you have fluid in the suprachoroidal space. What mechanism would lead to this? Well, we ended up finding a cleft on UBM, which was then repaired. This wasn't a zonule issue. The reason why I like to show this is look what happens to a patient that has fluid in the supraciliary space. What does that do to the anterior chamber? Well, if you think your anterior chamber has maybe 250 microliters of fluid, if I inject 100 microliters of fluid into that space, I'm going to displace 100 microliters out of my anterior chamber. That's why things appear shallow, especially when you get choroidal expansion. I want you to remember this because the mechanism of malignant glaucoma really does follow what you see with a cyclodialysis cleft with fluid filling the choroid or choroidal expansion. Now, this diagram is a little bit inaccurate, actually really inaccurate, because again, vitreous is not compressible. It is a fluid, but if you do have the choroid expanding and now you compress that vitreous, it's going to transfer a lot of that expansion pressure forward. So just increasing that choroidal volume by 100 microliters, it doesn't take much, will give you another 100 microliters of apparent shallowing on the anterior chamber side. The other interesting thing about this is if you think about malignant glaucoma in the traditional sense of aqueous misdirection with the ciliary body rotating backwards, it really does imply, as Dr. Quigley brought up, some type of a valved mechanism where you shoot fluid into a space, yet it can't go back out of that space. Again, that doesn't make sense because physiologically, there is no valve mechanism in the anterior hyaloid face and posterior to the iris. But if you think of malignant glaucoma as choroidal expansion, where fluid fills in the choroid and doesn't leave, then you start to realize that it's probably follows a spectrum of diseases that occur in that supraciliary space. So let me talk about a case here. This was a 63-year-old male, no prior surgery. He comes into the retina service with idiopathic choroidal effusions, huge systemic workup, all negative, and does have macular folds. His IOP is going up and his angles are closed. And so they sent him over to me. And I said probably the best thing to do initially was to do a cataract extraction to deepen the anterior segment, but you're going to need to do a scleral window or choroidal cut down of some sort in order to have that fluid leave. Part of the mechanism, I believe, that leads to these things is that the sclera is too thick and the permeability through there is poor. Pars plana vitrectomy alone is not going to solve the issue. So we end up doing the surgery, cataract comes out, the lens goes in, choroidals are cut down, fluid leaves, the choroidals and the macular edema resolve within a couple of weeks. Fast forward to 3 months later, the anterior chamber is now shallow again, despite not having a phakic lens, and he starts to have the macular fold. So then he undergoes pars plana vitrectomy and a peripheral iridotomy. So we do what we typically do to treat malignant glaucoma. And that actually deepens the anterior chamber because, again, even though you have the choroidal expansion in the back, you are now making a iridotomy for the entire eye. You allow fluid to move between the anterior and the posterior segment, and that deepened the anterior chamber, but it did nothing for the choroidals and the macular edema because that was a fluid extravasation issue. So if you look in angle closure eyes, these eyes adjusted for axial length and age have thicker choroid, and it correlates even with their thicker sclera. And so these are also the eyes that you will see malignant glaucoma occurring postoperatively at a much higher rate than other eyes. Let's go back to that case, though. This was actually a resident operating with me. When we operate on choroid, I think for a lot of us, like we were, that it's a really scary thing to do. In my mind, actually, it's probably one of the least nerve-wracking procedures that we can do when we're thinking about something that's so serious. And the reason is, when we cut it down from the outside, you take a closed compartment and you open it. And if we are going to do a scleral window, I actually don't do windows. I do a simple cut down about 3.5 to 4 millimeters back. You'll see that it's radial to the tangent of the limbus. And my goal is to get on top of choroid and see it and allow for fluid to come out. If you think of just doing like a spinal lumbar puncture, when we go in and you worry that you're going to hit a nerve, well, the nerves actually kind of move out of the way. Same thing with the choroid. As you cut down on it, it tends to move out of the way. And God forbid, even if you had a hemorrhage, which would be extremely unlikely, the compartment is no longer closed. The blood at least would extravasate out. But what I like to do is place a 4-0 silk suture through that initial cut down. I'm essentially trying to mimic closing that wound, but then take a Sinskey and pull a loop of suture out, cut it. So now I have two halves to create a little bit of traction. You can give one to your assistant, hold one in the other hand, and then you can cut down and really see once you get to that dark tissue that is the choroid. Now, in this case, remember, this patient had already had a scleral cut down once. And so we ended up taking a little punch of sclera in order to leave a permanent fistula for this fluid to leave, because his scleral permeability was the issue that was leading to the choroidals, leading to the macular folds. We did this over 3 different quadrants, and then I actually injected mitomycin over 2 of them in order to try to keep that space patent. He is, you can see how old this video is. He is probably 7 or 8 years out from his original surgery. Choroidals have not come back. If you look at him in the slit lamp, he has a couple of very low-lying blebs over 2 of his scleral cut downs. But I present that case because, again, this idiopathic uveal effusion that occurred presents like what we see in malignant glaucoma. The second case is actually very interesting to me because we do get referrals to our service for lens exchanges for refractive surprises. I say that because now this was not this patient, but he was 91 and he comes in, he had cataract surgery within our own department 20 years prior. So actually had the biometry and the lenses that were implanted. He had the exact same lens power used in both eyes with such like similar biometry between the two, but one side had a myopic result. That wasn't an IOL power issue. If you look at him on gonio, because he's sent to me for elevated pressures, the angles are actually closed on this myopic side. He had an anterior displacement of his lens iris diaphragm, giving him a myopic result. This was not, and sometimes we do get, again, it's not often, patients that have been sent in for myopic refractions that were shorter axial lengths that were actually in subtle malignant glaucoma. And that was the reason why they were slightly myopic. It wasn't because the IOL power was wrong. So our plan was, he was 91, we're not going to tube him. I am going to go and treat the mechanism. So I'm injecting right now just intracameral lidocaine. And when I inject the Helon, you're going to see that it just does not deepen. Zonules are not strong enough to resist the deepening by Helon. You inject just a little bit, it all comes pouring out. Well, it's because the vitreous is no longer able to be compressed any more than what it actually is. I like to take a coolant, identify my haptic, because what I'm going to do now is take the vitrector, make a very large iridectomy with the vitrector, then go in and actually go through the bag, the peripheral bag, maybe even zonules into the anterior hyaloid, and then remove vitreous about 3 to 5 seconds of a vitrectomy. And that will instantaneously deepen the anterior chamber once you break that attack, which is why sometimes you can get away with it doing it in clinic. If you look at the gonioscopy here, you see the trabecular meshwork is now open. This eye is much, much deeper. We remove the viscoelastic. The PIs are large on purpose because sometimes you can still get vitreous coming forward, blocking the peripheral iridectomy. But he's actually done well. And what was great with his case is it really did neutralize his spherical error. So he ended up closer to plano. What about eyes that you need to be aware of? And I think this is great for the comprehensive ophthalmologist. And these are cases that are going to be relatively rare, but when you're high volume, you will see them. If you're looking at patients that have axial lengths less than 20, and we'll talk about why that's important, less than 20, you add up all patients with an axial less than 20, it's generally about like 1 to 1.2% of the population is going to have this short of an axial length. So we don't see them all that often, but at a very high volume, you will. These are the eyes that should be concerning to you that are higher risk for post-op complications. And we'll talk a little bit about some of this data. When you're looking at patients with an axial length between 20 and 21, there is a higher complication rate than your typical cataract surgery is going to have with normal axial lengths. But where it gets really intense is when that axial length drops below 20. And then your complication rates can go up even 15-fold greater than patients that have an axial length of 20 to 21. And many times you will see patients that will do well with surgery. I'm not saying that, but these are the cases where I really start to consider adjuvant procedures and counseling them that, listen, you have a very small eye, you're a higher risk of potentially needing more than one operation after your cataract surgery. And if you look many times, about half of these cases, a little bit more, can end up with postoperative malignant glaucoma. So if you gonio and you see that angle closed after cataract surgery, usually within the first several weeks, you have to start thinking about it. What else can happen? Vitreous hemorrhages, dysphotopsias can occur, intraoperative, just high pressure sensation where you feel like there's a lot of posterior pressure, that can occur at the time of cataract surgery. So I do counsel these patients differently. For us, when they start to get into the axial length of the lower 19s and below, we then start to do adjuvant procedures. And what do I mean by that? It's either doing that iridozonulo-hyaloidal vitrectomy, like the case I just showed you where we did the vitrectomy through the iris, or even considering scleral cut downs in order to decrease the chance of uveal effusions. Now, this is based off of data. There was a small randomized study in Southeast Asia looking at patients that had very short axial lengths. If you look at their averages, both groups had an axial length average of 18, lens thickness 4.3, 4.2. And at the time of cataract surgery, they either underwent a scleral cut down, just in one quadrant sclerostomy, or they had just cataract surgery alone. And when you look at the data, I'm just going to point out to the only thing that actually really matters here. In the group that had the scleral cut down or the sclerostomy, there were no choroidal effusions intraoperatively and postoperatively. If you look at the control group with these short axial links, 4 out of the 31 had choroidal effusions that were documented. The reason why this matters is because intra-op, it can really feel like a lot of posterior pressure. And these are patients that can be higher risk if you look at posterior capsule ruptures, because you're starting to get that posterior capsule coming up against your phaco tip. And then post-operatively, they're at a higher risk of having malignant glaucoma. We get several referrals like this a year where uncomplicated phaco and the patient has post-op malignant glaucoma. Now, I kind of want to go into something a little bit fun as we start closing out, since we've talked about malignant glaucoma and the mechanism really is choroidal expansion. When I was a fellow, so now this is years ago, when I started, I really noticed that we got a few diagnoses of malignant glaucoma, and in residency, I just didn't really see it that often, and probably because I wasn't like attuned looking for it either. But then when the wintertime came, things kind of cooled off and we didn't see it as often. And then toward the back end of my fellowship, we started seeing these things occurring again. So I just thought, well, we're just operating more during the summer months. It gets cold in Toronto. Very obvious explanation here, but I still wanted to look at it. We had over 18,000 cases that I could look at within the practice where I had the biometry, the op reports, and we knew exactly what was going on. This is between 4 surgeons, and I excluded anything that was not routine with the cataract surgery. So it just had to be straight phaco. And afterwards, we looked, did they have any postoperative shallowing? And if they did, these patients had to have at least a PI, make sure there's no other cause for this, and treated down the malignant glaucoma pathway, which is cycloplegics, and then eventually iridozonular hyalodovitrectomy to break that sequela of the choroidal expansion. And so when we looked, we kind of started looking at a couple of things, and the way the data plotted out, without getting too detailed into why we came up with this, we started actually looking at the daylight hours instead of necessarily the temperature of the month that they had the surgery. And so malignant glaucoma actually occurred out of 18,000 uncomplicated phacos. It occurred only in 16 cases. This is an extremely rare event after cataract surgery, but it was an interesting thing to look at to try to elucidate some mechanism here. When you look at just the average daylight over the months in Toronto, it ranges between 9 hours of daylight to 15 hours of daylight, and the average is about 12. Well, malignant glaucoma in general, we noticed that it was diagnosed within a month, usually after their original cataract surgery, whether the AC was shallow or they had a little bit of more myopia. The practice is very attuned to doing goniooscopy and picking this up. But I was wrong, actually. We had an even number of cataract surgeries occurring in the longer daylight hour months compared to in the shorter daylight hour months. So the distribution was actually very similar throughout all months. And when you look at just the way when you plot the data, these malignant glaucoma cases actually clustered on average when there was more daylight. And so I started to think, well, is there something to it? The odds ratio is actually pretty significant. I mean, 4-fold difference in having malignant glaucoma if you had surgery in longer daylight hour months. And, I looked, I was like, well, maybe we just had the tendency to got lucky and you clustered shorter axial links when the daylight was longer. It just happened that the data fell out that way. Well, didn't look like that was the case either. The axial links were on average very similar between groups, whether they had malignant glaucoma in the summer months with more daylight versus in the winter months, winter months with less daylight. So then I came back to WashU, and it was right now just kind of like a curiosity, and I didn't really have much of a mechanism. So I was talking to our pathologist who has been around for a long, long time, and I was like, it's interesting. I noticed this data. What do you make of it? He's like, oh, it's it's funny that you mentioned that. We used to induce glaucoma in chickens by exposing them to light. I was like, what do you mean induce glaucoma in chickens? I was like, show me the paper, Mort. And so he's the first author on this. And if people in the glaucoma sphere will know Bernie Becker and Steve Potos, but I started reading in that paper. And sure enough, what they would do is they would expose chickens to light on 2 different cycles. So either they had a 12-hour cycle, or they had chicken exposed to light that was just running 24 hours just on an incandescent bulb. And when you expose a chicken to continuous light, that's the eye on the left, you can see that it's much larger than the chicken that is reared in diurnal light. And when you look at them, same eyes, different view, again, you see the buphothalamus, the larger eye of the chicken that was exposed to continuous light. And then if you look at the histopathology, this is the chicken that was continuous light. This is the chicken eye that was in a diurnal variation of light, typical of what you see normally. And you'll see here that the iris is plastered against the angle. This is an angle closure mechanism, and this angle is open. So it gets really interesting from here because, for me, I'm like, okay, well, they could induce angle closure and you could measure the anterior chamber shallowing with actually pachymetry at that time. And they really noticed that the angles were closed. The AC was much more shallow in chickens that had continuous daylight exposure. But then another researcher, Lauber, who also used the same mechanism to study glaucoma, or the same model, he did a different experiment. They actually treated the chickens with Diamox, and the pressures wouldn't be as elevated. They wouldn't have as buphophthalmic of an eye, but the angle would still be closed. So it would still have this posterior seaming pushing mechanism. But what was really interesting in what he did was he would patch one eye of the chickens and expose the other eye to continuous daylight. And when he uncovered the patch, the one that was patched was also buphophthalmic. So he kind of attributed this to this elusive systemic process, is what he wrote in the paper. And the reason why I bring this up is because, you think about like all the things that patients do in and out of the building, in and out of their homes. Is there something else going on? And the other interesting factor with malignant glaucoma is we see it heavily weighted toward women and women with angle closure. And so I want to impart you with this. I do think that malignant glaucoma is likely related to choroidal expansion, which in my mind really is a spectrum of disease that involves uveal effusion syndromes. I don't think that we need to be calling it aqueous misdirection because it just leads us down the wrong treatment pathway. Really, the reason things that we need to treat are scleral permeability. And if you're just trying to get rid of the angle closure, then make a large PI for the entire eye. But is there some type of a role in light or hormones in the development of malignant glaucoma? I think this is going to be really, really tough to tease out. I can tell you my personal preference. If we don't have to go into some of these small eyes because their pressures are really elevated and we have no time to act, I actually do preferentially like to do these cases, at least in my hometown, in the winter months when there is less daylight around. But generally, we're doing some of these ancillary things like iridozonular hydrovitrectomies or scleral cut downs to make these surgeries safer. But I really appreciate the opportunity to be here, and thanks so much.
Fascinating talk. Very, very interesting. Thank you. I want to remind everybody that if you want to ask a question, go ahead and raise your hand and we'll call on you. Well, we can also use the chat. We're keeping a watch on that also. So if you'd like to, go ahead and submit a question or raise your hand so that we can see. I have one question. When you do the scleral cut down, how do you decide if you're going to use mitomycin or how many quadrants you're going to use? Is there a way that you titrate it?
No, that's a great point. And that case is so uncommon where we did it once and then it ended up recurring after a couple of months. So I did the mitomycin because probably part of the problem was that scleral cut down I did just closed off. For these cases, I generally will do one quadrant, sometimes two, to be honest. And then we're typically looking at the axis length. If it's like in the low 19s or below, they're going to get a scleral cut down. And generally, it's very similar to what I did, but I typically don't take a scleral punch. Just cut it down, make the surgery a little bit less likely to have that posterior pressure build up. And usually then we'll do the iridozonular hydrovitrectomy in order to prevent that entire anterior chamber from shallowing in those cases.
Are there any questions from the audience? I think you wowed him with the chicken story.
Thanks so much.
All right, thank you so much. I would like to continue a discussion that Deb had started, recognizing Dr. Hill for his contribution to this program. We really owe it to him for, designing the program and helping us get the speakers and picking the speakers. These are nationally and internationally recognized experts in the field, and we have Dr. Hill to thank for that. So Warren, if you'd like to come on and say a few words, we would love to hear you. We really appreciate your guidance and your assistance in developing the program. I think the audience is grateful for your help, and we've enjoyed your talks in the past. They're always so informative. So thank you for joining us tonight.
Yeah, well, I hope you can hear me. Yeah, thank you very much, Ed. Well, it's just such a delight to put together a group like this of people that we're all going to learn, so much from. Actually, I share a desk with Yuri McKee, where he's my partner, and every day I learn something from Yuri, and I hope that all of you will have the same experience. And boy, there's just so many wonderful speakers like Andy Lee, and boy, I think this is going to be a really good program. So I'm glad you were able to make all this happen on your end, and let's continue.
Can I ask you one little challenging question?
Of course.
Because we all sit here and you've been doing the profession for decades, and we all are looking towards the future and our survivability into the future. And we're wondering what challenges you think are the biggest challenges facing ophthalmology or even medicine as a whole as we look forward in time. We have lots of young people on this conference also, and I'm sure they're interested to know what they're up against.
Boy, do you want this alphabetically or in order of importance? Holy cow. Well, it comes down to just a collection of things. One is going to be access. Dick Lindstrom has taught us that the number of ophthalmologists that are going to be practicing in the next 7 to 8 years isn't really going to change. In fact, in some specialties, it's going to go down. But the number of people seeking ophthalmic care is going to go up. Okay, so that's the substrate. And on top of that, we have declining reimbursements and pressures, from insurance companies. And so it's going to be some way to resolve, how do we handle this increasing workload with decreasing reimbursement and decreasing resources? And then technology gets better and it gets better. And of course, as technology improves, the cost goes up. And so, it's the old story of, why can an elephant be so big? Well, that's because the profit increases by the square, but the overhead increases by the cube. And in ophthalmology, we already start with a very, very high overhead. So that's going to be, it's a combination of things, it's access, it's economics, it's the regulatory environment. And boy, I really don't know what the answer was. If I could predict the future, I'd be on Wall Street, wouldn't I? So it's going to be tough. In my area, if I could offer just one pearl that actually Yuri McKee and I have come to the same conclusion on for refractive accuracy, and this is going to play a large role in what we do for our patients, because we're going to have to go outside of traditional insurance reimbursement. We have to get the refractive outcomes just dead on. We spot on with the refractive outcomes. And that is optimize the ocular surface before you do biometry. And I can guarantee you that one aspect, paying attention to that one thing, will increase your refractive outcomes and maybe have you have more happy patients and more multifocal lenses or torics, and make life just a little bit easier until something comes along and makes things even more predictable. So lots of challenges in the future, aren't there?
That's such a useful pearl. Thank you so much for sharing that. For all the work you've done on IOL calculations, it's starting with something simple like ocular surface. Make sure it's good. Thank you. That was so
what
helpful.
A difference it makes. Okay, well, let's continue with the program, eh?
Thank you.
Yeah.
Our next speaker is going to be Andrew Lee. And his talk is on neuro-ophthalmology, and it's defining life-threatening etiologies of diplopia, differentiating features of dangerous double vision, and the differential diagnosis for acute bilateral ophthalmoplegia. Dr. Lee is chair in ophthalmology and the founding chairman of the Blanton Eye Institute Department of Ophthalmology at Houston Medical Methodist Hospital in Houston. He's professor of ophthalmology, neurology, and neuroscience at Cornell Medical. He's had numerous leadership roles in the Academy, NANOS, AUPO, the Houston Neurologic Society, and Houston Ophthalmologic Society. So thank you, Dr. Lee, for joining us tonight. We're looking forward to your talk.
Great. I'll just ask if they can go ahead and start the video there, Ed.
Thank you.
Mark on there.
Mark?
Hi, and thanks again for having me. I'd like to talk to you about BMW CAR, the differential diagnosis of acute bilateral ophthalmoplegia. And if you can remember the BMW and the CAR, you'll know that the differential diagnosis is, and these are additional 5 diplopia pearls that can make a difference. And so the BMW stands for B, brainstem disease, botulism, and Bickerstaff, which is a form of the Miller-Fisher variant of Guillain-Barré syndrome with ophthalmoplegia from brainstem involvement in anti-GQ1B disease. myasthenia gravis, and the Miller-Fisher, of course, without the brainstem encephalitis involvement. And so the only thing that separates Bickerstaff and Miller-Fisher is they're on the same spectrum of disease, and they're both ganglioside related disorders, GQ1B being the prototype, but Bickerstaff has mental status change. And Wernicke, as well as CAR, the carcinomatous meningitis, and the cavernous sinus. So if you remember BMW, brainstem botulism, Bickerstaff, myasthenia, and Miller-Fisher, Wernicke, and the CAR, carcinomatous and cavernous sinus, I think you'll have a really good, strong differential diagnosis for acute bilateral ophthalmoplegia. But before I tell you about that, you need to know that the Reaper is coming for your patient's eyes or your patient's life. But the Reaper also is coming for us. And in the end, the Reaper always wins. And I'll tell you how we can defeat the Reaper in our own way. And the Reaper for professionals and doctors, especially ophthalmologists, is burnout. So the Reaper is coming for your very soul. Every day we battle the Reaper, and your superpower is looking in people's eyes, seeing, detecting, and deflecting the Reaper. And the other way the Reaper comes to us is in the form of physician burnout. If you look at burnout by specialty nationally in the United States, this is the AMA data, the average of all physicians is quite high. Ophthalmology is 43%. Now, we're not as bad as neurology or ER or internal medicine, but it's a problem. And if you look at the causes in the Maslach burnout inventory, emotional exhaustion, depersonalization, and loss of personal accomplishment are the most common things that people say. And I really can't do anything about a lot of the things on this list, but today's lecture will end with how I deal with the Reaper. And I think that by having professional fulfillment, that we can overcome all these other things, which are really quite small in the grand scheme of things. So let's just start with this case. It's a 36-year-old white male who has acute, painless, bilateral ophthalmoplegia. And then we're going to just add in the extra little distinctive symptom or sign that will help us differentiate amongst BMW CAR. But as soon as you have this case where he cannot look up, he can't look right, he can't look down, he couldn't look left, you should be thinking BMW CAR from the start in this acute bilateral ophthalmoplegia. So if you have this patient in the ER, the first thing you need to make sure is not brainstem. So any of the killer B brainstem symptoms, we're going to image, of course, and the imaging study of choice is going to be CT plus CTA non-contrast initially, followed by MRI, MRA. And in the outpatient center, we're just going to start with MRI, MRA. If you have altered mental status, if the MRI is negative, you should be thinking about the Bickerstaff brainstem encephalitis and doing a lumbar puncture for the CAR, carcinomatous meningitis. If you have a history of alcoholism, bariatric surgery, eating disorder, or hyperemesis gravida of pregnancy, and the MRI is normal or may show some non-specific changes, you should be thinking about the Wernicke. And in the Wernicke, even if you don't see the classic white matter lesions in the bilateral periaqueductal gray and in the mammillary bodies, and medial thalami, even if the MRI is normal, you should really be thinking about giving thiamine to acute bilateral ophthalmoplegias, especially in high-risk patients. If it's variable and fatigable, we already talked about myasthenia gravis, and that's the grave in gravis. And that, of course, is going to have a negative MRI, normal pupils. And the ascending polyneuropathy, ataxia, areflexia, and albuminal cytologic dissociation of the CSF, high protein but normal or near normal CSF white count with an MRI negative. That's the stem for the Guillain-Barré syndrome. And when you have the ophthalmoplegia, that's the Miller-Fisher variant of Guillain-Barré, but it's a spectrum. And so if you have altered mental status and brainstem involvement, that is Bickerstaff's brainstem encephalitis. So these are the killer Bs: difficulty breathing, difficulty speaking, difficulty chewing, difficulty moving your arms and legs, difficulty with your numbness or tingling, or whatever the brainstem symptoms are. These are the Ds of brainstem disease. And so we're really looking at the periaqueductal gray and the thalamomesencephalic junction for the patients who have the third nerve palsy predominant, but it can extend down caudally into the pons. So it really doesn't matter whether it's horizontal, bilateral. Ophthalmoplegia is always going to be brainstem at the top of the differential diagnosis when we have a bilateral acute ophthalmoplegia, and that means imaging of the brainstem. And there's all sorts of killer B symptoms that are associated with midbrain and pontine lesions. This just happens to be examples of the midbrain brainstem syndromes: Weber, Benedict, Nothnagel, Claude. You've heard all these names where you have hemiparesis or extrapyramidal signs or ataxia or some combination of these things. And it's really not that important that you memorize the syndromic eponyms, but it's important that we have a full neurologic exam in any patient who has acute bilateral ophthalmoplegia, because we were looking for these other brainstem killer bee syndromes. And also the same thing for the pons. So if it's a horizontal ophthalmoplegia, it does not have to be a complete ophthalmoplegia. We're going to be looking for the pontine syndromes that are associated with ophthalmoplegia in the brainstem. And it can look like a 1.5 syndrome. This is an adduction deficit here with an abducting dissociated horizontal nystagmus. It's named for the side of the medial rectus dysfunction. This is a 1.5 syndrome. And it can become a bilateral horizontal gaze palsy or a 1.5, or it can be paralytic pontine exotropia, or it can be a bilateral internuclear ophthalmoplegia, or any combination of these horizontal gaze problems. You still need to be thinking about BMW CAR. So if it's vertical, we're thinking about midbrain. If it's horizontal, we're thinking about pons. And of course, you got to check the other cranial nerves. So here this patient has a 7th, and also in A, you can see they look relatively straight, but then they can't have a horizontal gaze palsy. In B, they can't look to the right, and on gaze to the left, they have an internuclear ophthalmoplegia. Their up gaze is also decreased, and that's going to put the lesion right here in the brainstem in this diffusion weighted imaging. And the 7th is a tip off that it's a pontine localization here, pontine, causing the 1.5 syndrome. If the pupil is involved, either a unilateral or bilateral fixed, non-reactive dilated pupil, again, you have to be thinking about brainstem and that pupil involvement. If it's bilateral, you have to think about botulism as well. So in myasthenia gravis, of course, you're not going to be involving the pupil. So if it's pupil spared, myasthenia rises to the top of the differential, especially with a negative MRI. But if their MRI is negative and it's bilateral, internal and external ophthalmoplegia, and the patient is awake and alert, you really should be thinking about botulism as the other B once the brainstem B is eliminated with imaging. So here's just a case of botulism. The patient's awake and alert. They have a complete external ophthalmoplegia with bilateral ptosis, but their pupil is dilated. You need to remember that there are different forms of botulism. Infant botulism, so don't give honey to babies because the spores can cause the botulism, or adult intestinal toxemia from foodborne botulism or wound botulism, and person-to-person transmission of botulism does not occur, and it tends to start in the muscles of the face and then spreads. So we've got an awake, alert patient with bilateral internal and external ophthalmoplegia with a risk factor for botulism, and bilateral dilated pupils with a negative imaging study. You really should be thinking about botulism. Here's a case where you have a lesion in the cavernous sinus and it's extending bilaterally. This is also on CAR. So CAR is both carcinomatous meningitis and cavernous sinus involvement. And in the PET scan, you can see the bilaterality of this metastatic lesion to the cavernous sinus. You should know that the ganglioside antibody disorders, both Bickerstaff's, Guillain-Barré syndrome, and Miller-Fisher variant are a spectrum from PNS to CNS involvement. In the Miller-Fisher variant, we have anti-GQ1B antibodies, which here's the GQ1B. It looks very similar to Campylobacter jejuni's glycoprotein. And so there's autoimmune molecular mimicry that leads to the production of anti-GQ1B antibody. And that presents with the classic ataxia, areflexia, albuminocytologic dissociation of Guillain-Barré, and an ascending polyneuropathy. Albuminocytologic dissociation means elevated CSF protein, but a normal or near normal CSF white count. And if you can just have the ophthalmoplegia, which is kind of like a Miller-Fisher variant without the rest of the Guillain-Barré syndrome. But once it gets into the reticular activating system and the reticular formation with impaired consciousness, even though it's the same disorder in terms of its pathogenesis, the anti-GQ1B antibody mimicked by the Campylobacter jejuni glycoprotein, impaired consciousness and altered mental status is what characterizes the Bickerstaff brainstem encephalitis. You should also be worried about Wernicke. Now, of course, Wernicke has imaging characteristics. You can see the hyper-intense bilateral symmetric involvement, medial thalami, periaqueductal gray, that is characterized by the Wernicke syndrome causing the ophthalmoplegia. And any patient who has encephalopathy, disorientation, indifference, inattentiveness, or any form of oculomotor dysfunction, including acute nystagmus, but particularly lateral rectus palsy, or any combination of those Pontine syndromes, INO 1.5 syndrome, 6 nerve palsy with ataxia of gait and stance. If you see the white matter lesions, of course, it's obvious that it's Wernicke, give the thiamine. But if MRI is normal, you still should give the thiamine, especially in those high-risk characteristic patients, alcoholism, hyperemesis gravida, bariatric surgery. So the differentiating feature between the Wernicke and the botulism is the botulism people are completely awake and alert, and the Wernicke people often have altered mental status. So that's one of the differentiating features, is botulism preserves consciousness, Bickerstaff's and the Wernicke do not. Myasthenia doesn't involve the pupil. And so if you have acute painless bilateral ptosis, ophthalmoplegia, normal pupils, negative MRI with variable and fatigable ptosis or variable and fatigable ophthalmoplegia, that's the stem for myasthenia gravis. You already know about Lees-P's, no pupil involvement, no pain, no perception loss, no paresthesia. So you should always be thinking about myasthenia gravis in any acute and painless bilateral ophthalmoplegia with or without the ptosis. You already know about the pupil-involved third nerve palsy and how if it's bilateral, we really should be worried about brainstem disease, but it could also be cavernous sinus and also carcinomatous meningitis. So in summary, hopefully what I've covered for you in these 15 minutes is, if you're presented with a young white male in the ER with acute painless bilateral ophthalmoplegia and any of these plus signs, you should be thinking BMW CAR. Any of the other killer B symptoms, brainstem, diplopia, dysphagia, dysarthria, difficulty talking, difficulty walking, difficulty speaking, ataxia, these are the signs or symptoms that should suggest brainstem involvement, and we're always going to start with a CT in the ER, followed by MRI, MRA, because MRI is better than CT for the brainstem. If you have altered mental status, that is one of the differentiating features that suggests it could still be reticular formation involvement. That's the Bickerstaff, or the Wernicke encephalopathy, because both Bickerstaff and Wernicke have encephalopathy. Myasthenia gravis and botulism do not affect level of consciousness. If you have a risk factor, such as alcoholism, bariatric surgery, eating disorder, or hyperemesis gravida, especially if the MRI scan is normal, just hit the person hard with thiamine. I give IV thiamine, 500 milligrams TID for several days. We also give concomitant magnesium to these patients. And that's the Wernicke, the W in BMW. If you have variable and fatigable ptosis with normal pupils and a negative MRI, and there are no Lees-P's, no pupil involvement, no pain, no paresthesias, no perception loss, you should be thinking about myasthenia gravis. And the gravis in myasthenia gravis is they could get respiratory failure and die. You should think about the Guillain-Barré syndrome, but the entire spectrum of anti-ganglioside antibodies, but the prototype is GQ1B. When you have an ascending polyneuropathy, ataxia, areflexia, and albuminocytologic dissociation, high protein but normal or near normal CSF white count, that is the A's of the Guillain-Barré syndrome. If you have the ophthalmoplegia, we call that Miller-Fisher variant Guillain-Barré. And so at the end, I told you, when the God of death comes for you or your patient, what shall we say? In the end, the God of death always wins. But what we say, both professionally against burnout and to the Reaper when he's coming for the acute bilateral ophthalmoplegia patient, not today. And so my first and second mountains are in PubMed. You can see I'm on my second mountain here in 2021. You are my second mountain. There's only one thing to say to the devil of physician burnout, not today. So I enjoy giving these talks. I'm happy to be with you, even if it's virtual. You are my second mountain. You are how I achieve professional fulfillment and defeat the Reaper. And so every day in clinic, not today, not today, not on my watch, not today. It's the only thing we should say to the Reaper. And you should be thinking about BMW CAR in any acute bilateral ophthalmoplegia. And if you just look at those plus differentiating features, I think you'll have a really great differential and be able to defeat the Reaper when he comes to visit you and your patient. And I thank you for your time and attention. Hello, my name is Andy Lee, and I'm going to be talking to you about 5 life-saving diplopia pearls. I want to thank Sumaya and the organizers for inviting me today. And I'm sorry we can't be there with you in person. I have no relevant financial interest to disclose. My father would say the definition of a bad lecture is if he changes the channel. A good lecture changes your mind, and a great lecture changes your behavior. So hopefully I'll be changing your behavior in terms of diplopia, because what will happen if you don't make the diagnosis and the conditions I'm going to describe, I see dead people and blind people too. And as if death weren't enough, I love this sign. It says touching wires causes instant death. But there's also a $200 fine. Well, if the $200 fine is not the motivation, well, death certainly should be. So here's the overview. 5 dire diplopia scenarios. If it's not isolated, and by not isolated, I mean pain or other cranial nerve palsy, then you should work it up. An ophthalmologist should be able to count to 8, 5, 6, 7, 8. Those are the cranial nerves that are in contiguous nature to each other. And so when you have a 3, a 4, you need to check the 5. When you have a 6, you have to check 5 and 7. And we have to at least get down to 8. If you have any other neurologic findings, weakness, numbness, headache, nystagmus, ataxia, if there's aberrancy during the regenerative phase, that's usually a compressive lesion, or if there's a history of cancer. When it's a third nerve palsy, you should be very worried about that. And if it's bilateral or progressive or acute and getting worse, then you have to worry about that. And if the pupil's involved, either a small pupil, that's the concomitant Horner syndrome, or a big pupil, that's third nerve palsy, or if there's a relative afferent pupillary defect. So here's a patient with acute diplopia and headache. Is this a dire diplopia? They're 55, they have new headache and diplopia, nausea, vomiting. The field shows a bitemporal hemianopsia, and they have a pupil involved third nerve palsy at the same time. Well, this is a dire situation because we're getting both the afferent and the efferent system, the bitemporal hemianopsia from the suprasellar extension, but the lateral extension into the cavernous sinus is what is producing the third nerve palsy. And you can see here the hemorrhage surrounding this hypointense core, and my poor chiasm and cavernous sinus are feeling the afferent and efferent compression. This is a different patient. It's the last patient of the day. It's 4:55 p.m. on a Friday afternoon. They're 60, they have diabetes and hypertension, new onset ptosis of the right eye, diplopia for 2 days, elevation, depression, and adduction deficit in the right eye. So what's the most important part of this exam? And what are we going to do? Are we going to call neurology, neurosurgery, neurology, neuroradiology, all of the above? So here's the patient. They have a complete ptosis and an ophthalmoplegia. Well, this is the highest stakes encounter that an ophthalmologist will see. And we need to do a non-contrast CT first. And what we're looking for is this subarachnoid hemorrhage. And aneurysms account for about a third of the third nerve palsies. Unruptured, the rate of subarachnoid hemorrhage is 1 to 3%. But once you get a rupture, you have a 50% chance of dying at the scene. Half the people never make it to the hospital. And the symptomatic aneurysm rupture rate is 2.4 times higher than the asymptomatic rate. And so we'd like to treat this aneurysm before the rupture. This is the highest stakes encounter that an ophthalmologist will see. In the typical 60-year-old with hypertension and diabetes, this patient could be a vasculopath, in which case it's just going to go away by itself, live, or it's going to rupture and they're going to die. Half the people who survived the rupture and the subarachnoid hemorrhage are permanently neurologically impaired. And so treating the patient before the rupture is super important. So here's the aneurysm causing this third nerve palsy, and a diagram showing a stent-assisted coil is going to be placed here. And you can see here this peanut right here. That peanut is the aneurysm of the posterior communicating artery. And this is post-endovascular coiling, and you can see we have a complete obliteration of that aneurysm, and that's a cure. Have a nice life. So there's a risk stratification for these third nerve palsies. In the red zone, the highest risk, subarachnoid hemorrhage, and worst headache of my life. It doesn't matter what the pupil is doing in that third nerve palsy. High risk, pupil-involved third nerve palsy. That's the rule of the pupil. A pupil-involved third nerve palsy is an aneurysm of the posterior communicating artery until proven otherwise. Moderate risk is partial pupils or partial palsies. That is, the pupil is still reactive, but it's slightly larger, or not all the divisions of 3 are involved. That's a moderate risk that still needs imaging. And the low risk is the one you learned in the book, a isolated vasculopathic pupil spared third nerve palsy. You could observe that. However, you might still image that. And lowest risk if you just have a dilated pupil, that's the lowest risk. Or if you just have a ptosis, that's also the lowest risk. So translating this into the Lee Homeland Security color codes, in the red zone, subarachnoid hemorrhage, third nerve palsy, you need a non-contrast emergent CT, and you might need an angiogram after that, especially if it shows subarachnoid hemorrhage. And in the orange zone, pupil involved, third nerve palsy, that's going to need an urgent angiogram of some kind. In our hospital, that's non-contrast CT followed by CTA, MRI, MRA, and then angiogram. In the yellow zone is the moderate risk, partial palsy or partial pupil, CT, CTA followed by MRI, MRA, and you might still need an angiogram in that setting, depending on how high your pretest probability of disease is. And in the blue zone, the vascular path, complete, pupil spared, third nerve palsy. You might observe that, but no one would fault you for doing MRI, MRA in that setting. And in the green zone, a dilated pupil alone or just ptosis alone. I generally don't do imaging for third nerve palsy for those cases. Those are more likely to be adhestonic pupil or pharmacologic dilation. And for the ptosis, it's much more likely to be a benign form like levator dehiscence or myasthenia. Those are the lowest risks. And so the key question is, when you're dealing with a third nerve palsy in a diabetic patient, such as in our case, you're asking yourself, do I need to work this up? Is this a diabetic third? And if you add in the RAPD, then that's not aneurysm anymore. So once you have the afferent and efferent, the RAPD, and in a diabetic, the thing we'd be worried about is an orbital apex lesion, such as mucor, but you should also be thinking about pituitary apoplexy. So when you have that afferent and efferent problem, you really should be thinking about pituitary apoplexy, orbital apex lesions, and in a diabetic, mucor. This is Lee's rule of cancer. This is a 65-year-old patient with a history of lung cancer and diplopia. And the rule is, it is that cancer until proven otherwise. And if it comes to me from the cancer hospital in our city, that's the University of Texas MD Anderson Cancer Center, a hospital devoted just to cancer, then it is that cancer until proven otherwise. So my behavior change ask for you is, instead of just writing lung cancer, please write the stage and whether there's recurrent or metastatic disease. This helps us stratify how likely this is to be the cancer. So PMH stage 1A lung cancer, status post gross total resection in 2000 with no recurrence or metastasis, versus stage 4 lung carcinoma, status post resection with multiple liver and brain mets, status post chemo and radiation therapy. Well, obviously patient number 2 is a way higher risk of having the cancer be the cause. And of course, if it comes to you from oncology or from the cancer center, or the person has metastatic cancer, it is that cancer until proven otherwise. So any diplopia in a cancer patient is dangerous. So Lee's rule of cancer, if the chief complaint is any age, old patient with a history of cancer, insert cancer, and any neuroophthalmic complaint, it is that cancer until proven otherwise. You should know that it can always be myasthenia gravis, especially if there's no P's. So the reverse is also true. Before you make the diagnosis of myasthenia in any pattern of ophthalmoplegia, even if it looks like a standard 6 or third, you must make sure there's no P's. The P's are no pupil involvement, no proptosis, no pain, and no loss of perception or paresthesia. The reverse is also true. If you find any of Lee's P's, pain, pupil involvement, proptosis, perception loss, that's the RAPD and the afferent side, or paresthesia, you really should think that's a dire diplopia. So Lee's P's equals A, not myasthenia, but B, it's something bad and that you should work it up. In addition, you need to have emergent imaging if it's bilateral and progressive. Bilateral and progressive is a big problem. And once you add in the Lee's P's, the pupil involved, a small pupil, that's the Horner syndrome, or a big pupil, that's the pupil involved third nerve palsy, that is also a big problem. I want to end with one example of this bilateral and progressive and how dangerous it is. The case is called, his name is Andrew. It's a 33-year-old white male with transient dizziness, blurry vision, followed by loss of consciousness after watching bungee jumping at the Iowa State Fair. So he was doing this 2 hours. Wow. On regaining consciousness, bilateral ptosis and exotropia, eyes turned out. Non-contrast CT and ER was normal. MRI with contrast was quote unquote normal. He's about to be discharged. However, he developed the top of the basilar system syndrome and was given intravascular TPA because he actually had a vertebral dissection. He got locked in, he recovered slowly, he walked out of the hospital, and he wrote a book about his own experience called One Fine Day. It's written up in ophthalmology as a neuro-ophthalmic emergency. Years later, I receive a phone call from this patient. Hey, Dr. Lee, you don't remember me probably, but I had a stroke at age 33 and you helped me at Iowa. Sure, I remember you. I was just calling to let you know I went back to college. I got married and now I have a new baby. His name is Andrew. Me, that's so great. Congratulations. No, Dr. Lee, you don't understand. His name is Andrew. So in summary, these are the 5 dire diplopia scenarios that I hope that will make a behavior change for you in your clinic. You need to make sure it's not isolated or that it is isolated. And by isolated, I mean you checked the other cranial nerves, you asked about pain, because severe pain and any other cranial neuropathy is badness. You need to be able to count to at least 8 because the nerves are contiguous. 3, 4, 5, 6, 7, 8. And now you've heard about 2 in that list. You need to be able to go from 2 to 8. The 2 is RAPD. Make sure there's no RAPD. And then once you involve the pupil, that's Lees-P's, and that converts that diplopia to a dire diplopia. There shouldn't be any other neurologic finding, weakness, numbness, headache, nystagmus, ataxia. If they develop aberrant regeneration or they have a history of cancer, that's Lee's rule of cancer. It is that cancer until proven otherwise. Any third nerve palsy, you must do the Lee homeland stratification for risk. The highest risk, pupil involved with worst headache of my life, but pupil involved and partial pupil are all dangerous. And I would recommend that you consider imaging all third nerve palsies, unless it's clearly just a dilated pupil, which isn't a third nerve palsy, or if it's a complete vascular path, isolated and getting better. Even that one, you might still consider imaging. Our imaging study of choice, non-contrast CT in the beginning for subarachnoid hemorrhage, followed by contrast CTA. And if it's negative, you still need an MRA after that, because MRI is better for the non-aneurysmal causes of third nerve palsy. If it's acute, bilateral, or progressive, you need to worry. And in the acute setting, you must ensure that it gets better or document that it's getting worse. If it's getting worse, image it. And Lees-P's, if the pupil's involved, and if you have anoscoria, small pupil, Horner syndrome, or big pupil, third nerve palsy, or you have RAPD, big pupil equals big problem. And I thank you for your time and attention.
What a fantastic talk. Thank you, Dr. Lee. We have Dr. Lee joining us live. To answer any questions, I'll remind you, you can raise your hand or you can use the chat. Fantastic talk. When they pull me away in a straitjacket as I'm burned out from my office and I'm mumbling Lees-P's, maybe you'll explain to them why I'm saying that. Well, just your opinion. We have notables from all around the country here with us tonight, and we're very curious about what your opinion is about the greatest challenges facing ophthalmology now.
Yeah, so for me, and I think for everybody, part of our burnout problem is the electronic medical record has made it so much easier to look at stuff, but now we have too much information. So it's like too much stuff going on. And I envision a day where machines would collect the data and we wouldn't have to waste our time on clicking, and we could spend our time talking to patients and doing surgery, and let the machines collect the data, let the machines document the data, and let the machines talk to each other when they're documenting. And I think that day is coming. And for me, I would like to see a day when we spend our time with our brains and our hands and not so much clicking and looking at computers.
Yeah, it's certainly a big challenge. All the clicking. Sometimes when I'm just looking for efficiency, you say, how can I decrease the number of clicks that I'm doing, and where's the real information that I need to know hidden somewhere in this EHR? So
I see a little question here if you'd like me to answer it live, or I can type the answer. The question was, why should we have thiamine in bilateral ophthalmoplegia in hyperemesis gravida? And so people who are vomiting all the time are at risk for developing the Wernicke. So hyperemesis gravida is the vomiting that you get, which lay people call morning sickness in pregnancy, and then you're not eating, and so you could get Wernicke. So even though Wernicke is classically described in patients with alcohol abuse disorder, you should be thinking about the Wernicke in any ophthalmoplegia that's bilateral as part of BMW CAR, not just in alcoholic patients, but in patients who have hyperemesis gravida, malabsorption syndromes, eating disorders, bulimia, anorexia, or bariatric surgery.
Looks like there's another question. Does Dr. Lee have lectures on YouTube?
So you can come visit us on YouTube. Our site is Neuro-Ophthalmology with Dr. Andy Lee Nodal. It's free. It has over 4 million views and has 59,000 subscribers. So it's completely free. Come visit me on YouTube. And if you have any question at all, I'll answer it for you on YouTube.
Very nice.
One more question from Steve Thornquist there, Ed.
Would you comment a bit about internal ophthalmoplegia in this setting?
So external ophthalmoplegia just means it's the lid and the muscles, extraocular muscles. Internal ophthalmoplegia is our fancy way for pupil involvement. So internal ophthalmoplegia is the pupil, and the pupil can have a problem with being too small. That's the Horner syndrome, as we mentioned, or it can be too big. And that internal ophthalmoplegia on the parasympathetic side is indicating of Third palsy. So any patient with ptosis, motility, or pupil, you must look at the other two. And if you have 2 out of the 3, that's bad. But if it's 3 out of 3, pupil, lid, and motility, that's super bad. And so if you have 2 out of 3 or 3 out of 3, you should go to the ER.
Great, thank you very much. In the effort to stay on time, thank you, Dr. Lee, for joining us. I'm going to turn this over to Dr. DeLuise.
Thank you so much, Ed, for your superb moderating. And again, thank you to Deb Osborne, the executive committee of CSEP, and thank you, Warren Hill, for inviting this superb group of speakers tonight. Our next speaker is Dr. William Trattler, whose topic this evening focuses on the early diagnosis of keratoconus and the promise and future direction of collagen cross-linking in this disease. Dr. Trattler is well known as a refractive cataract and cornea surgeon at the Center for Excellence in Eye Care in Miami. His clinical and research focus is in complex cataract surgery, collagen cross-linking for keratoconus, pellucid marginal degeneration, and post-LASIK ectasia. He's also knowledgeable and an expert, a national expert in dry eye disease, MGD, and treatments for presbyopia, having participated in over 70 clinical trials. He's published extensively on all of these subjects and has given remarkably over 400 presentations at regional, national, international meetings. He's a co-author of the Review of Ophthalmology, the Ophthalmology Board Review book, and another book that I find personally very useful, which is the Cornea Handbook, which he has co-authored with Paraj Majmudar and Jody Lux. Dr. Trattler cannot be here with us tonight live because of weather-related and other issues, but he's kindly provided us a pre-recorded video, which is an update on keratoconus and where we are today with cross-linking. So we'd like to have Dr. Trattler's video. Thank you.
Hi, I'm Bill Trattler from Miami, Florida, and I'm very honored to be part of the Connecticut Society of Eye Physicians Scientific Regional Meeting. My topic is Advances in Cross-Linking and the Management of Keratoconus. I'm based in Miami, Florida. This is in case anybody wants my contact information. And so it's very exciting to be part of this great agenda, this great program, and I hope this proves to be very helpful. These are my disclosures. Probably the most relevant are Avedro and Glaucos, where I'm a speaker, CXLO, I have a financial interest, and Oculus, where I'm a speaker. So keratoconus is a progressive disease. We know the risk for progression is higher in younger patients, eye rubbers, and more advanced keratoconus. However, patients of any age can progress, and crossing is effective at stopping progression regardless of age. So no matter what age, patients who have crossing can have their progression stopped. The question is, what percentage of patients may still progress following epi-off cross-linking? And it is important to understand that while cross-linking is very effective, it's not 100%. About 2 to 3% of patients who have undergone cross-linking can still progress. It's important that we follow these patients every year, whether they've had cross-linking or not, to identify progression. I hope that's one of the things and pearls you'll learn from this talk, is that keratoconus is a condition that requires constant follow-up every year to make sure that their maps are stable and that they're not progressing. Here's some just the basic evaluations. Here's a patient. This is a fellow eye of a patient with more advanced keratoconus. But you can see how there's very little keratoconus in their eye when they first presented, a little mild inferior steepening, but then they presented 2 years later. You can see it's significantly advanced with the steeper part of the cornea getting steeper. But what's also interesting is the flatter part of the cornea gets flatter. So it's a reshaping that occurs with keratoconus. The steep part gets steeper, the flat part gets flatter. Here's another example of a 13-year-old who came in. Again, this is the fellow eye of a patient with more advanced keratoconus in the other eye. They come back 2 years, 10 months later, you can see significant keratoconus has developed. And what happens to the shape? Well, again, the steep part gets steeper, but the flat part's also getting flatter. So what we're seeing is a reshaping of the cornea with keratoconus. Now here's a patient. Here's a 48-year-old patient, and they came in, and we talked about cross-linking back in 2010. It would be experimental. There's no FDA-approved version at the time. They waited, and they came back just recently in November of 2022. You can see they've significantly progressed, and this patient had central steeping, so it actually wasn't. It was just very much in the center of the steepen. And you can see that this patient had a significant change over this 12 years. So you can see different patterns of change over time. And I just want to point out this pattern. So how common is keratoconus? Well, this study for the Netherlands found that the prevalence was about 1 in 375. So it's common, but not super common in this particular evaluation. But then other studies have found a much higher prevalence. So in India and Israel, it's over 2%. In China, almost 1%. Iran, 2.5%. And Saudi Arabia, believe it or not, is almost 5%. So it's quite common in certain parts of the world. Australia was 1.2% as well. So we're seeing this more and more as we have better technologies to identify keratoconus earlier. But the challenge is that often patients are going undetected. Here's an example of a patient who has 20/20 uncorrected vision in both eyes. Okay. And look, this is their maps. This patient, believe it or not, can see 20/20 on the charts. They're able to drive the car and do everything. They do have some ghosting, and they can be, unless you have them in for another reason, they may not realize that they have keratoconus. This patient had a family member with keratoconus, and thus we were able to identify them. But they did have 20/20 uncorrected visual acuity tested on multiple days on the chart. Here are more examples of patients with keratoconus, and surprisingly enough, all of these patients were able to see 20/20 without glasses out of this eye on multiple visits. So quite impressive, and again, that's why some patients may slip under the radar because they're not coming in for eye exam. Now here's a patient who's 28-year-old male, completely normal slit lamp exam, and this is their Kmax 58.3, and they actually saw 20/25 without glasses in this eye. Now, thankfully, screening can be very helpful. So this is a family member of mine. At age 9.5, she came in. She had normal topography. As you can see, not much of a refractive error. She's 9.5. Again, my family member. So, of course, I wanted to be a good father and perform topography. So I had a nice baseline for her. And surprisingly enough, she came back at age 12 years, 9 months with loss. Her uncorrected vision had gotten worse. She developed some myopia and astigmatism. And the question is, should we perform a screening topography? Now, it's pretty easy in retrospect. The answer would be yes, and thankfully we did. But this is how she looked 2.5 years later after her normal topography. You can see she's now developed keratoconus in both eyes. And thankfully, I was involved in a clinical trial at the time for cross-linking. She was able to have cross-linking at age 12. This is how she looked 5 years later. You can see she has significant improvement over time, where the steep part of the cornea is going to get flatter, and the flat part gets a little bit steeper, so she reshaped. A pretty nice improvement in the first 5 years after her cross-linking procedure. And this is, again, part of an investigational protocol. Here's her left eye, same type of improvement, nice flattening, and she's done very well. She's now 10 years out from her cross-linking treatment. Now, we know that kids have a very high risk of progression, and so that's one of the things it worked out really well for me to just be proactive on my daughter. The other group of patients where we see a lot of patients coming in with keratoconus are patients who are kind of in their late teens, 18 to 22, and coming in for a refractive surgery consultation. And this study that looked at 1,000 candidates overall found a pretty high number of patients, almost 5%, that had signs of early keratoconus or even more advanced keratoconus. And so again, these groups of patients coming in for refractive surgery often will have keratoconus. So important to look out for them overall. So again, going to kids, when you do identify a child with keratoconus, it's important we recommend cross-linking because they do progress. There's quite a high risk. This is an older study, but found that 88% of kids progress overall. So again, once you identify them, treatment can be quite effective. Now, here's a patient that unfortunately had delayed their treatment. Here's what can happen. So she starts off with some kind of a pellucid-like pattern, and then she comes back 18 months later with some significant progression over time. The difference map shows the steep part got dramatically steeper. She actually, again, the flat part got flatter. You can see here. So she progressed with loss of best corrected visual acuity. So again, delay in treatment can lead to significant progression in children. Here's a patient who's in their 40s, and it's important to understand that patients in their 40s can progress as well. And so you can see that over this time period, they had a 3.4 diopter Kmax increase, and it's really right in the center where they had this increased change. So again, patients in their 40s can progress as well. Now here's a 70-year-old patient with early keratoconus. They had their Kmax is 52.2. So kind of an interesting looking, kind of a sideways keratoconus where there's a little asymmetry from side to side, but they came back and you can see the significant change over time. And then the difference map shows this dramatic increase in irregularity in the shape, and they did have cross-linking at this point. Now here's one of the more challenging patients, quite an interesting patient. She came in at age 53 with a occlusive pattern, and then came in now at age 62 with the same pattern. So no change over time. So it's very happy, very stable. I saw her every single year. Again, she's in her 50s when I first started seeing her, stable, we're doing well. Okay, let's keep watching. No need to cross-link at this point. We talked about it, but we did not proceed with cross-linking. So we delayed, no need to do cross-linking. And then she came back a year later from age 62 to 63. And now she's developed this change. So while she was stable for 9 years, now she has this change, and her Kmax went up to 51.5. You can see now she's got kind of this occlusive pattern style worsening. So her Kmax overall increased by 3.6 diopters over this time. So we talked about cross-linking, and she was very interested, but as you can see, it was actually during the time of COVID. It was March of 2020. So she's like, let's just wait. And she did. And then she came back. And the question is, will she progress further? And how quickly will she progress from age 63? She did rubberize some. She didn't say she's a terrible eye rubber, but she did have some eye rubbing in her history. And so she decided to wait. And then she came back at age 65, and now she's progressed even further. And you can see the dramatic worsening. She developed 11.6 diopters of worsening, steepening, and it's only at this point that we were able to cross-link. So the point being that you can be stable year after year. It doesn't mean you're going to be stable for the rest of your life. And that's why all patients, regardless of age, should have annual topographies to look for changes over time. Again, we performed it in April of 2022. Cross-linking. So besides keratoconus and occlusive pattern, we also want to watch for patients who had previous LASIK and look for ectasia. So this is what we expect after previous myopic LASIK, a nice blue flat center. And this patient has this area of steepening right in the middle. This is an area of early ectasia after LASIK. Here's another example, a little bit more advanced, where instead of having this blue round central area, you have this area of steepening right in the middle. So again, this is early ectasia. It often will have this type of pattern. It's kind of like a V pattern or a triangle pattern where the blue area is being lost, and you're starting to develop some steepening. So you can see an area of steepening, and you still have the flat area in patients with previous LASIK. And as it gets more advanced, you lose the superior border, where before you could see that there's a little steeper area around the flat blue zone, but now you lose it as the bottom part of the cornea gets even steeper. Again, this is a reminder of what it should have looked like. And this patient has ectasia in both eyes. Now, genetics of keratoconus are quite interesting. There's not a single gene that's been identified, but there is a company that's working very hard to help us identify patients who have genetic risk for keratoconus. These patients have these susceptibility genes on 75 different loci or genes. Again, it's not a single gene, but this group of genes that we have to watch out for. And here's an example of a genetic test result where you have kind of a low risk, moderate risk, and high risk group of patients. And it's quite interesting as we look at these patients to help understand their genetic risk for keratoconus. Now, one question is, do patients with a history of previous who've had LASIK developed ectasia, do they have risk factors, genetic risk factors for keratoconus? So this is a paper that Tori Hirschman, one of the medical students, presented at the CXL experts meeting in Zurich just a few months ago, last month. And we looked at 26 patients with post-LASIK with ectasia, either after LASIK or PRK. Most had surgery prior to 2010. The mean age was about 34 when they underwent LASIK or PRK. And so it was quite an interesting group of patients, and we tested them. Their average age was about 52 at the time of testing. And we did the genetic test to see whether there was a high risk for the genetic risk for keratoconus. And interestingly enough, 22 of 26 patients had a score that was in the moderate risk, And we had 3 of 26 patients that had high risk of keratoconus, and we had only 1 patient that had low risk of keratoconus of these 26 patients. So genetic testing actually showed that the patient that developed ectasia after LASIK or PRK did have a high risk, moderate to high risk of having the genes for keratoconus. Again, this is an early study. We don't have a control group at this point, but just again, an interesting finding. So we did find 2 genes that are a little more common. You could look at Google to kind of review these genes. It'll be interesting to see as we understand more how these genes might be impactful at increasing the risk for keratoconus, and there's more work that needs to be done. Again, this is still early. We're looking at patients now that have had LASIK without ectasia to understand what the risk is, and of course, it was only 1 eye that had PRK. The other 25 had previous LASIK. So the purpose of cross-linking, just to go through why we're here and why we're talking about cross-linking, is we wanted to stop progression. But it's going to be interesting to find out, I'm sure many of you have seen this, is that we often will see improvement in corneal shape, which means that patients can get improvement in their uncorrected vision as well as their best corrected visual acuity. So here's an example of a patient who had cross-linking in 2017. They came back in 2020, and now their shape of their cornea looks very symmetrical. There's no more skew of the axis. Again, these are very uncommon to have this amount of improvement, but it's always exciting when this happens after cross-linking. You can see the difference map where the steep part got flatter. The flat part actually increased, it got steeper, and as it reshaped, the patient had improvement in vision because they were much more symmetrical. Now, what about patients that are very steep? So here's a patient that had a very steep cornea, Kmax is 81.3, a little bit on the thinner side, 372, best corrected visual acuity is 20/80. They underwent cross-linking as part of a clinical trial at the time. And you can see they came back 5 years later with improvement in best corrected visual acuity. Their Kmax had dropped to 68.9. And then again, they got this significant flattening of the steep part of the cornea and a little reshaping as well. And that's why they had the improvement in best corrected visual acuity. Now, one thing that always comes up is that when you have advanced keratoconus and actually scarring from eye drops or other reasons, should you just give up and just perform a corneal transplant? Well, it turns out that our contact lens technology has really improved over time. And these are cases from Ed Boschnick. All these patients are seeing quite well with their scleral lenses. They're all quite happy. They avoided corneal transplant. They're able to drive, function. And so even if a patient has a corneal scar, with scleral lens technology now, patients often can be quite happy with their vision and avoid the risks that are associated with corneal transplants. So thankfully, in 2016, we had approval of cross-linking. What's currently on label is for keratoconus and ectasia after refractive surgery, after PRK, SMILE, LASIK, any refractive surgery. Pellucid marginal degeneration is considered off-label, but it's thankfully quite rare to have a true case of pellucid. You often see pellucid pattern keratoconus, but pellucid marginal degeneration is a little less common, and thankfully, while response to cross-linking, it is considered off-label. And the question is, can we consider cross-linking for patients that are with off-label conditions? And I think that it's true that we don't have, while being on label is nice, and that's often how we get insurance coverage, off-label treatments can work quite well. So we're going to talk about corneal thickness in just a bit. And so even if they're thinner, they can actually do quite well with cross-linking. Again, any patient who has ectasia is actually on label. So that's important to understand that they're all on label. You don't have to demonstrate progression to be on label with ectasia. Pellucid pattern keratoconus just means a crab-claw pattern, but where the steepening is, the thinning is actually not too far peripheral, and that actually is quite on label. And then children, even if you're under the age of 14, which is off-label, patients can progress very well. I shared my daughter had treatment at age 12, and adults who are concerned about further progression. For example, if they have progressive keratoconus in one eye, you might still want to treat their other eye as well. So thankfully, there's an approved procedure, and as you know, it's an epi-off procedure where we remove the epithelium, we soak the cornea with riboflavin, we check at the slit lamp. While the indication is flare, I'm really looking for saturation of the cornea with riboflavin. Then we measure the corneal thickness. Our goal is to be on label is to be 400 microns only at this point. So if you start off at 280 microns, remove the epithelium, swell them to 400 microns, you are on label at this point. And then we irradiate with UV light for about 30 minutes. We've had a nice improvement in insurance coverage over the past few years. It's really been very helpful for our patients. And that's something to look at is, for insurance coverage for those of you that are doing that, it has improved quite a bit over the past few years. We always work to get pre-authorization before having patients undergo the procedure. And so there's just conclusions on iLeak that, again, we work very closely with our optometry colleagues as well as our ophthalmology colleagues to help identify, monitor, and follow patients over time. We really aren't co-managing crosslinking because the procedure itself, typically we're doing the actual treatment and the early follow-up at our office, but then patients do follow up with their optometrists for further evaluations, and we work in conjunction with ophthalmologists as well as many other ophthalmologists in our area for these patients. Now, just a couple of misconceptions about cross-linking, that cross-linking only stabilizes the cornea. First of all, we often will see improvement in corneal shape over time. So that's a pretty exciting finding. That preoperative corneal thickness is a major issue, is a misconception. We can treat patients that are quite thin, actually, because the preoperative thickness is not part of the label. It doesn't matter whether they're 200 microns. That doesn't mean they're necessarily going to be off-label. It's just the thickness at the time of UV light treatment. So you can start with someone who's 240. If you can swell them after removing the epithelium, they are considered on-label during the treatment. But patients who are off-label of thinner corneas actually can benefit with cross-linking. So also that older patients over 30 do not progress. As I've shared with you a number of cases where we've demonstrated progression in patients who are in their 30s, 40s, 50s, 60s, and 70s. So yes, any age of patients can progress. And it's important to continue to have continued evaluation following cross-linking because while it's very effective, 1 to 3% of patients can still progress. So we need to have them come in and perform follow-up visits year after year. So what is the minimum preoperative corneal thickness according to the FDA label? Again, it's not pre-op corneal thickness. It's actually at the time of the UV light administration. So what we can do is we can actually thicken patients with hypotonic riboflavin. So in the FDA clinical trial, which I was a part of in 2008, we did have a lower limit of 300 microns. That's not part of the label, but we had started with patients 300, 305. Again, removed the epithelium, which is often much thinner. So it's not, you're not going from 300 to 250. It might be 300 to 280. Then you swell the cornea, and then we could initiate the therapy, the UV light treatment at the time. Again, here's an example of a patient that was actually quite thin, 368 with a pretty steep cornea. They underwent, at age 15, so there's a 15-year-old patient. This is, again, part of a different clinical trial in 2013. And we felt that since the patient was already so steep, it would make sense to perform the treatment. It was an epi-on treatment, so the epithelium was not removed. We followed the patient, and you can see they came back 5 years later. The Kmax was pretty stable, which is great. The patient had not progressed further. There's some changes in the corneal shape, and overall the patient was quite happy with their vision. Thankfully, we prevent them from further progression by stabilizing the cornea with cross-linking at age 15. Again, our goal within patients is first, when we identify them, they're often very steep. Some of them can have genetic conditions like brittle corneal syndrome or other genetic conditions. Our goal really here in these thin patients is to avoid a corneal transplant. If we could stabilize them, they can often wear scleral lenses and maintain excellent, very good vision with scleral lenses. We also know that patients with post-LASIK ectasia, they may not be as advanced, but they may be thin because they had LASIK, and so that was the reason their cornea is extra thin. But they can do quite well overall. So one thing to understand about cross-linking is that in thin corneas is that UV light, which was thought maybe would be toxic to endothelium, actually it's likely not the case. So this is a very interesting study that was published in 2016, where they actually took patients, they took human donor corneas, they treated some eyes as if it was going to be cross-linking with riboflavin loading, and other eyes were controls. And they flipped the light over, and they actually radiated the eye just as we do with the cross-link procedure, and we radiated the endothelial side in the study. And you can see that there is no difference in the endothelial cell counts between those that had riboflavin loading and those that did not, that were the control group. So it turns out that likely riboflavin loading with the crossing procedure does not increase the risk for endothelial damage, even in very thin corneas. UV light is not toxic to the endothelium. Let's take a sip. So for our thin corneas, we do have some options. We can swell the cornea as we discussed, and actually shorten the administration time. Our standard treatment time is 30 minutes of UV light, but you can actually shorten it to 10 to 25 minutes. It still gives an effect. It can be repeated as well. And that's what I've done for some of the ultra thin corneas below 200, where I've treated for just a shorter time period. It's also important to understand that some patients may need repeat cross-linking. So we talked about that the success rate's quite high. I tell my patients it's between 97 and 99% success with one treatment, but that means that they continue to watch patients over time. The patients that are at higher risk for progression are those that rub their eyes. So we do spend some time and try to explain to patients why it's important to not rub their eyes. Some patients aren't rubbing because of itching. Sometimes itching is the issue, and they have allergies. But other times it's a habit where patients feel better when they rub their eyes. There's this ocular cardiac reflex where it changes your feeling of how you're feeling. And so patients do feel better. They're often, if they're stressed and they rub their eyes hard, they'll feel a little more relaxed. So it does become this cycle where patients are just rubbing their eyes and it's making them feel better. So it's important to kind of discuss with patients the importance that we stop eye rubbing, and that will result in less progression before having cross-linking, and as well as after cross-linking, lowering the risk that they'll actually need to have a second treatment. Here's some studies. This is the original paper from Dr. Theo Seiler in 2009 that found about a 7.6% chance of needing a second treatment for progression. A paper by Dr. Antun in 2015 with epi off crossing found about 3%. And in my experience, it's been between 1 and 3% doing both epi on in various clinical trials, as well as epi off is about 1 to 3%. So it's not common, but as you do more and more patients and we follow them longer over time, they can progress. So it's important that we discuss this with our patients over time. So why do patients progress? Well, there are a couple of reasons. One, if we don't load the cornea well, so for those doing epithelial on cross-linking off-label, which would be where you would use the FDA-approved UV light source, and you could try using the FDA-approved riboflavin and try to load the cornea without removing the epithelium. It is very difficult to get enough riboflavin in the cornea, and that could lead to inadequate riboflavin loading, and you may not get a full treatment of cross-linking. Another area that I found that's really important is that in patients with central keratoconus, we center the light directly on the cornea, just right in the very middle. But if patients have a pellucid type pattern where the thinnest part is not central but inferior, we actually want to decenter the epithelial removal to the more inferior and have the patient look up during the UV light treatment. So we're treating the bottom part of the cornea more than the top, and we treat the weaker part of the cornea. So that's important. If you just treat centrally, you may be not adequately treating the bottom part of the cornea, and that could lead to some progression. Again, we talked about eye rubbing as well as elevated IOP. That can also be a risk factor for progression. You can also see the pseudo-progression where patients they have keratoconus and they wore the contact lens pre-op, so their preoperative scans are inaccurate, so it's hard to know if they progressed or not. So we do try to get our patients out of their contacts for the final imaging. We use Pentagon, but the final image we take before the treatment, which is the day of the treatment, to try to get a very good scan with them off of contacts for a few days so we can get a good scan, and that would be our baseline. And then also when they come back, if they've been wearing the contact, sometimes that can also impact their eyes. Scleral lenses sometimes can press on the sclera, cause some central steepening, and that can make the scans inaccurate. And of course, dry eyes. I have patients where they look like possible progression. Often they're just a little steeper, but they don't follow the typical pattern of progression. And you treat the dry eyes, and actually they're not truly steeper. It's just a bad scan. You can also see pseudokeratoconus, which is this patient here. The patient was thought to have keratoconus. They had 20/60 vision, best corrected visual acuity 3 years after cataract surgery. They thought they had keratoconus, but actually they did not. You can see it's just not a typical pattern. We have this flat area. That green area is the flat area. The red steep. It just didn't, not a typical pattern because you wouldn't expect to see a red area below the flat area in keratoconus. And it turns out that this is the left eye, again, a little superior steepening, again, not a typical pattern for superior keratoconus. And the condition that they had was epithelial basement membrane dystrophy. So we actually treated this patient with epithelial debridement, and the patient actually had a nice improvement in their best corrected visual acuity. So this is pseudokeratoconus, and you do have to watch out for those type of cases. So what happens 5 years after cross-linking? We often will see improvements in the corneal shape. Again, this patient is part of a clinical trial, but you can see how the steep part got flatter, the flat part got steeper, the Kmax went down, and you'll see, just like I shared with my daughter getting better, each year you can see a little bit of improvement year after year. So it's a pretty nice treatment over time that we get this further improvement. Here's an example of a patient. Again, they start off with Kmax of 55.8, then they got 2.8 diopters flatter. They came back 2 years later post-op, and then they were 3.5 flatter. At year 3, they were 4.3 diopters flatter, and they eventually got to 6 diopters of flattening at year 5. And they often will slowly continue over time. It's usually a little faster flattening to begin with and slows down the rate, but we see continued flattening over time. Here's a patient from 2014 looking at difference maps. You can see that, again, the same patient, you can see how they got flatter over time. So it's pretty exciting, and these patients were, of course, pretty happy. So in summary, keratoconus is a progressive disease. It's important that we continue to follow patients over time. A patient can develop keratoconus after previous corneal surgery as well, so we want to watch for that. So for my patients that have had previous LASIK, for example, I do perform topography every year on those patients. We want to look at difference maps, which can identify changes over time. That's one of the technologies I find is most useful at identifying a patient that's progressed or is getting better, because you have the baseline, then you look at the change over time, and you can see specifically each spot that's getting better, and we'll typically see specific patterns where in progressive keratoconus, the steep part gets steeper and the flat part gets flatter. Following cross-linking, we expect the steep part to get flatter and the flat part to reshape and get steeper. We talked about that while cross-linking is effective, there's still 2 to 3% of patients that 1 to 3% of patients can progress. So we want to follow them year after year. And of course, annual visits with topography are critical for all patients with keratoconus, regardless of whether they've had cross-linking or not. So I really appreciate everyone being here. I love answering more questions. Feel free to email me anytime with a case, with a topography, with a Pentacam, with questions. I love helping, and I really appreciate being part of this great meeting. Thank you.
Thank you very much. Thank you very much, Phil. That was a terrific talk, a comprehensive talk. Just a couple of points before I go to the question that Dr. Alan Stern is asking, which is that keratoconus is something that you will see in your practice. It may not always be evident. If you don't have a corneal topographer, even placido disc imaging can actually help you look at and see and discern irregular astigmatism. Keratoconus does not have to be an inferior steepening disease. It can actually be superior. Whether pellucid marginal degeneration and keratoconus are part of a spectrum of diseases is one of the great debates in the cornea specialty, but they clearly are both ectatic diseases. What Dr. Trapper didn't go into because of time constraints from what I listened to on the talk this evening with all of you is what about epi on versus epi off? As a PRK surgeon for many years before I retired, certainly the patients who had PRK, which is an epithelial off procedure, had more discomfort in the first couple of days. There's always the risk of corneal ulceration with the absence of the epithelium versus the LASIK patients, which were almost invariably happy on day 1. But epi-on, so therefore epi-on, you might think would be a great advance in this whole cross-linking journey that we are all on now, whether you are doing it yourself, whether you are referring patients for it. And there's some exciting data from Doyle Stulting's work as the monitor for the epi-on procedure. I want to mention also cross-linking is being done for fungal keratitis because it does work as an antibiotic. Interestingly, it can sterilize surfaces. There's a nice article in Review of Ophthalmology in October of 2021 for those of you that want to learn more about the various companies involved in cross-linking, and that's Christine Leonard's article in October 21 of Review of Ophthalmology. Excuse me. So that's what I want to mention about keratoconus. Also, the fact that it can be seen more in patients with Ehlers-Danlos syndrome, Marfan syndrome, osteogenesis imperfecta, and Down syndrome. So look for syndromes with your keratoconus and look for irregular astigmatism. It's more common than you think. So very important points. And I think that's going to help us in the future to screen out patients who probably certainly should not have LASIK or other flat procedures, and perhaps more would be wanting a surface procedure or no procedure at all for refractive surgery if they do have this problem. So those are my little quick and dirty thoughts about cross-linking. And I do think that the future of cross-linking is very bright. I have no financial interest, but in watching this from the outside. There's a question from Dr. Alan Stern to Dr. Trattler, who I don't believe is on live. He was trying to get on live, at least for the end of his talk, but I don't believe he's on live. Dr. Trattler, when you do treat a patient with 20/20 acuity, best corrected visual acuity, you often find that BCVA is no longer 20/20 because of irregular astigmatism, and do you warn these patients with this difficult discussion? I am not a cross-linking surgeon. I've never done it because I retired before cross-linking became ascendant. But I would hope and think that this would be a question that would be on a consent form beforehand, that visual acuity could not be guaranteed, and it may actually get worse. One of the things that I've noticed about cross-linking to date, unless someone in the audience has more updated information, is that it's still a relatively large ablation. And we don't target it the way we can target things now with wavefront guided excimer laser surgery, so that when you are reshaping the corneal surface, you're not necessarily reshaping it in a focal area, you're reshaping it in a global area. That might be, and I don't know, Alan, maybe you know more than I, that might be one reason for variable visual acuity outcomes in cross-linking until we have more ability to target the cross-linking procedure. So that's my thought. That's my thought about my answer. But maybe you should ask that question to Dr. Trattler directly. I'm sure Deb has has his contact information. I think maybe Dr. McKee, who also has a great experience in this field. Dr. McKee, do you want to chime in on the question that Dr. Stern asked about postoperative visual acuity not being 20/20 because of irregular astigmatism?
Sure. So yeah, that's obviously, as you said, should be on the consent. You are going to flatten the cornea in most cases. That is going to cause a hyperopic shift. So you might not be 20/20 for that reason. The cornea does get slightly hazy. It tends to clear over time, but you can tell your treatment is working because you can look at the slit lamp and see that demarcation line where it's been treated, and that may cause that. People with keratoconus often have a multifocal cornea, so even after presbyopia, they can still read and see distance because they're using different parts of their cornea to focus through. And so, I think it's good to stratify these people by age. So, Bill was showing a lot of examples of younger people getting cross-linking. And if I ever diagnose keratoconus in a young person, I would absolutely recommend cross-linking, period. The chance of progression is so high, you just have to cross-link them before it gets worse. For an older adult, I often watch to see if it's progressing. And until it does, I may or may not cross-link them, with the exception of people who need cataract surgery and are looking for some type of a refractive cataract surgery. And then I tend to cross-link them before the cataract becomes visually significant, because as he showed, over many years, you can still have flattening. And I want to see stability of that cornea over a long time before I do a refractive cataract procedure on them, lest they waste their money and continue to drift hyperopic because of the procedure, which can be over years. So absolutely, it can get worse. But our concern here is avoid a transplant. And so when I compare, well, you might not be 20/20 uncorrected versus, well, now you need a transplant, the odds are that I'm going to recommend cross-linking.
Thank you so much for that excellent and experienced response. Apropos, Dr. McKee, it's my pleasure to introduce him at this time. Dr. McKee specializes in corneal transplant techniques and premium cataract surgery and anterior segment reconstruction. Prior to his training in ophthalmology, Dr. McKee served as an active duty Air Force flight surgeon, where he attained the rank of major. He's former medical director of the Aerospace Medical Clinic and course director of the Top Knife U.S. Air Force Flight Surgeon High Performance Aircraft Course at Luke Air Force Base in Arizona. Dr. McKee has many other aspects of his biography, which you can read in the online agenda. And this evening, he's going to present an update of the latest techniques in corneal transplantation. Dr. McKee.
Well, thank you very much. Let me start to share my screen here. And I will bring up the presentation. So I'll give you an update on corneal transplantation today. As you heard, I'm Dr. McKee from East Ophthalmology. As you heard, I also share a desk with Warren Hill, and he noted that he's learned so much from me. And it's a deal we have that for every 10 pearls that Warren gives me, I exchange one. That's all I can afford. But it's a great exchange for me. Now, these are my disclosures at the bottom of the slide, but there are no relevant financial interests in this talk for me with any company that I consult for. So let's start with the history of corneal transplantation briefly. This was discussed even in the ancient Greeks, or even before that, 4,000 years ago in India or Egypt. But the first reported successful transplant, at least in animals, for xenografts or even allografts, was in the 1800s, maybe around 1830 or 40. And then the attempt was made for porcine human xenografts These all failed in 1844 with Kassam. Von Hippel developed a circular tree fine and then began doing successful animal keratoplasties. And even at this time, they were trying, instead of a full thickness transplant, just an anterior lamellar transplant, oftentimes successful. And then eventually in 1905, Zerm did the first successful human transplant. This wasn't cadaveric tissue. The patient was a gentleman who had been exposed to alkali burns in both eyes. Sadly, the worst prognosis for a successful corneal transplant. And then there was a young boy, I think he was 13 years old. He had a scleral wound that had left him no light perception. So that eye was enucleated, and then immediately the cornea was divided into two 5mm grafts, which were then transplanted. One failed and one was actually successful and regained a functional vision for this patient, although not perfect vision. Well, other things that happened after Zerm proved this possible was that Elschnig was now promoting using cadaveric tissue. And then, of course, Castroviejo was a big name in popularizing corneal transplants in the United States. Eye banking is, of course, critical for transplants, and Peyton established the first eye bank in New York in the 1940s. Surgical microscopes helped in all aspects of ophthalmology. In the 1950s, Zeiss introduced the first one. Ethicon introduced tenon nylon suture, which was designed for corneal transplants in the 1960s. If you look at this flow here, we're going from 1900 to now 60, 70 years later now, getting into more modern techniques. And then the success rate in the 1930s on 20-year data was about 22%. But by the 1980, the 10-year success rate was 90%. So this was a century of PK with some occasional DALC. And even Barricare in the 1960s proposed and even demonstrated a hinged posterior lamellar keratoplasty. But these were just some one-off ideas for lamellar keratoplasty. It really never took off. This was a century of PK. And the fundamental idea with PK, while it did improve over time, really didn't change for 100 years. Well, there was a lamellar keratoplasty awakening in the late 90s and really in the early 2000s. Mellis was instrumental in this from the Netherlands. He reported his first case of a lamellar posterior keratoplasty with an incision via the limbus in 1998. Now, in another type of lamellar keratoplasty, the deep anterior lamellar keratoplasty, which had been performed successfully over the years, even back to the 1980s, Anwar showed us how using air to dissect Descemet's membrane off stroma in his big bubble technique could make the DALC procedure easier and more relatable to more surgeons. But the big change was dissect. Descemet's stripping automated endothelial keratoplasty in the 2000s. Around 2005, it really started to take off. And then in 2006, Mellis did the first report of a successful DMEC, which is Descemet's membrane endothelial keratoplasty. So this is the EBAA, Eye Banking Association of America data, and it's showing us the number of transplants. You can see in around 2011 to 2012, PK was overtaken by all forms of endothelial keratoplasty. At that time, it was primarily dissect. Around that time, Frank Price and Mark Gorovoy were probably the two most prominent names in forming rules for how surgeons should do DMEC and working out the surgical steps and techniques. And you can see ever since then, endothelial keratoplasty has well overtaken penetrating keratoplasty in terms of numbers. And it as early as, or as late as 2021, doubled up the number of EKs versus PKs. You can see ALK really has not taken off. I'm going to show you some cool things about why ALK should be more prominent. There's a number of reasons, though, why it hasn't taken off. You can see it was kind of popular around 2012 to 2015. That kind of dropped off after COVID. It hasn't quite recovered. There was a little dip for all transplants, of course, due to COVID. And K-Pro has probably decreased a little bit. There was a little mess up with reimbursement where it made it nearly impossible to do for a while. The problem with keratoprosthesis is that 5 years or so seems to be the limit for how long most eyes will survive before they go NLP from glaucoma or infection with K-Pro. So that's still a work in process, although there is a K-Pro available in the United States with a Boston keratoprosthesis. But if we just zoom in on, again, just the total endothelial keratoplasties, we'll see here that dissect still is the number one, but it's almost on par with DMEC. And now PK, DMEC, and DSEC are all pretty much equal in terms of their numbers. And I think we're going to see DMEC continue to improve their numbers. As you can see, just a meteoric rise there from 2012 to 2021. It's better for a number of reasons, which I'll explain. Let's just make sure we're all speaking the same language here. You all know what a PK is. It's penetrating keratoplasty. All layers of the cornea are removed through a tree find. The button is removed. A new donor is brought in, typically oversized by about 0.5 millimeter, and then sewn in place with 16 sutures. Well, a DSEC is a microkeratome dissected graft at the eye bank, where the center of the graft is between 50 and 100 microns typically these days. The incision size is about 4 to 5 millimeters. You can see in the middle picture there's about 5 temporal sutures. And you can also see the edge of that DSEC. It makes a little white scar, but that's all inside of the normal cornea. And then if we look over to the picture of DMEC, you see that you can't see the graft. I've had referring surgeons call me and say, I really appreciate that you fixed my patient's eye. I just wish you'd been honest with me. I said, well, what are you talking about? I said, well, you didn't do a transplant. You did some voodoo and it's fixed. I'm like, no, there's a transplant. You just aren't looking at it the right way. I can teach you how to find it, but it's very hard to find. Now, I can tell you that that picture of that DMEC is less than a week old. Why? The suture's still in place. I always take the suture out about 1 week out. So these grafts clear quickly, they melt into the back of the eye, and they look perfect even by a week. The OCT picture that I have below that is not the same patient. I've shown you that OCT to demonstrate the tissue that's gets transplanted. You see some small peripheral edge detachments of the DMEC, which is not present in the photograph. So DMEC is just decimase and endothelium transplanted. So penetrating keratoplasty was typically used for keratoconus or for stromal opacities or ulcers or endothelial failures. These were the big reasons. Indeed, the number one reason for penetrating keratoplasty in the 1980s was endothelial failure from phacoemulsification. So now I only use penetrating keratoplasty when all layers of the cornea are compromised. Example, a ruptured ulcer. I might do 1 or 2 PKs a year at this point. I used to do 15 a week. So the numbers for my PK have just gone down to 0. I hope I remember how to do it next time I have to do it. Why is PK volume falling? Well, you just watched a great talk by Bill Trattler, and you see that ectatic disease is now being treated by cross-linking. And it's so effective, and we're doing so well at catching people with keratoconus and cross-linking them. I can't remember the last keratoconus transplant that I did. And then additionally to that, even if you have an irregular cornea, that used to be an indication to do a transplant when it couldn't fit a regular rigid gas permeable lens, but a scleral RGP can be fit on nearly any cornea these days. And if surgery is indicated because you can't fit a scleral RGP, then deep anterior lamellar keratoplasty is, in my opinion, the better option anyway. What about corneal opacities? It turns out that you might look at a scar and you might think that's interfering with vision, but what really interferes with vision in the cornea is corneal irregularity from scarring, which can be fixed with a scleral contact lens, RGP. And once again, if surgery is indicated because the scar is too dense, deep anterior lamellar keratoplasty is the better option. There are a number of reasons why people have these opacities, such as inflammation and neovascularization. We're getting very good at making corneal neovascularization go away and the intensity of the scar go away, and then fixing the irregularity of the cornea with a scleral RGP covering it up. And of course, endothelial disease, Fuchs dystrophy, used to be widely treated with a penetrating keratoplasty. The standard is absolutely endothelial keratoplasty at this time. And in my hands, the standard is absolutely DMEC, especially for something like Fuchs dystrophy. This move was required, though. This is not a bad thing. There are several problems with penetrating keratoplasty, and I clearly remember, as a resident or a fellow, being called in the middle of the night to see a sweet old lady with her PK button in her hand from minor trauma, asking me if I still needed that piece of her eye to sew back together. And those are heartbreaking cases. So relatively minor trauma could dislodge a PK graft even years afterward. Anyone who's done a repeat PK knows that you don't retrefine it. You just simply grab the graft and pull it out of the eye at the time of surgery. The steroid load was immense to prevent rejection, and still not that successful, but high dose steroids would lead to glaucoma, and typically when you looked at a PK, you'd also see that trab up on top of the eye. And of course, it'd lead to infections, especially fungal infections and suture-related infections and infiltrates. So immune rejection, too prevalent despite chronic topical steroid use, which has its own set of problems. Ocular surface disease was very prominent. Of course, you're by definition making a neurotrophic cornea by cutting a big circular trepanation mark. So chronic problems with ocular surface disease. And then of course, irregular astigmatism is common after penetrating keratoplasty. Before I ever did a PK, I made sure patients knew their expectation should be a hard contact lens to see well after full healing. Of course, full healing would take 1 to 2 years, and they'd be on steroids this whole time, so the wound was never healing well. And there's arguments about should sutures stay in for 1 or 2 years or stay in forever, or take them out only if they break. These were a lot of problems that we had with PK, and endothelial keratoplasty just solves them. Well, you might say, but well, maybe when a PK fails, you'll just replace the PK, right? No, not me. Now, if the PK is grossly ectatic and got a lot of trouble or huge scars, maybe I'll just replace the PK. But most times when people come with a failed PK, they simply have endothelial failure. This is a case of about a 1-day post-op DMEC, I think. Look at the rim of that cornea. It's quite hazy. That's what the entire eye looked like when this patient came to see me. I've placed a DMEC under his PK, just within the confines of the graft. You can't find this DMEC. You can't. You can see the trab up there. Not surprised that they have one from years of steroid use. I've only got 3 10-0 sutures in here, and that's just so I sleep better. And you can see a little gas bubble. Most of the gas has gone into the bleb, but his cornea is crystal clear. I've got a couple of OCT images. You can see that the cornea is still a little thicker than normal, but the edema has cleared up even overnight. And I took this other picture on the bottom. The OCT shows just a slight graft attachment, which is not of any worry to me. I'm just demonstrating that that's what the DMEC thickness is. And you can even see the fibrous encapsulation of the bleb in that OCT as well. So for me, if you have a failed PK due to endothelial failure, I'm going to replace the endothelium with a DMEC. You're going to keep your original PK, especially if it's reasonably well healed and you have well-fitting contacts, or you'd achieve good vision with that PK. You just need more endothelial cells. We're seeing this now 20 or 30 years out. Many PKs just don't have enough endothelial cells. They wear out over time. And it's fairly straightforward to replace them with a DMEC, which you're going to learn later greatly reduces the risk of immune rejection. Well, let's talk about DSEC for a second. We're replacing the dysfunctional endothelium with a lenticule of stroma, and then of course decimase and endothelial attached. And this is really good for complex cases, tubes, trabs, vitrectomized eyes. It's mandatory in aphakia or aniridia. You're not likely to lose the DSEC lenticule in the posterior segment with a non-intact iris lens diaphragm. It's possible. It's not likely. You can use suture fixation or suture pull-through techniques to reduce that, but a DMEC will fall through a hole in the iris or through the pupil very easily, and it can cause fibrosis or PVR in the posterior segment. So here we have an OCT showing you what a DSEC looks like in place. This is an ultra-thin DSEC, 57 micron graft centrally. I like to keep my grafts around 100 microns. You see the edges of the graft are much thicker. And I have aphakia, aniridia, large iridotomy, or unable to comply with the post-op positioning required for DMEC as absolute indications to do a DSEC over DMEC. Severe corneal edema that prevents visualization of the anterior segment during surgery, penetrating keratoplasty, filtering glaucoma surgery, or prior vitrectomy are all relative contraindications of DMEC. But I have done DMEC in all these cases. And as you get more experience doing it, you learn the tricks, you can offer it in these cases with confidence. So let's look at a video of DSEC. So this is a patient who had a vitrectomy and they had endothelial failure. They had a little bit of scarring. Turns out that scarring goes away with DMEC or DSEC. But you can see the scar there in the conjunctiva in the upper right side. So vitrectomized eye in a patient that can't lay flat, older patient, let's just give them a DSEC. It's a little bit easier. They're going to do better with it. Here I am using an AC maintainer to keep that eye inflated because the entire eye will collapse very quickly since they've been vitrectomized. They're already pseudophakic. As I said, I'm removing the depleted decimase and endothelium, and now I'm making a generous incision, 4.5 millimeters. I don't want to compress my lenticules. I put it into the eye. This is the pre-cut graft from the eye bank. It's about 100 microns in its center. The endothelium is facing us. I'm pulling the lenticule onto my Busen glide. And then this is a Tan forceps by Donald Tan, designed to pull, dissect into the eye or to manipulate on the spatula here. You can see the spatula will allow me to just kind of curl this up so the endothelium is on the inside of the graft. And then I reach across and I grab it. And my infusion's off. The eye's going to get really soft here just for a second. But it's controlled by my foot pedal. I grab that graft, I pull it in through my generous incision, and then you'll see as soon as I touch my foot pedal, it unfolds the graft form. Just deepens the chamber, and we are done right there. See, the graft's open, and I know the endothelium is facing the iris because that's the way I pull it in there. Then I put some air in there, but you see, I'm still holding my graft with my forceps. I don't want that to go anywhere. And once I get some air just to kind of hold the graft and also supporting with the forceps, now I can hold my wound closed. I don't have a spare hand to do a stitch because it's holding the graft. And then I can very, very carefully remove that forceps. It's a little tricky because the forceps wants to close to go through the wound, but the edge of the graft is right there. Quickly secure my wound with a stitch and now put more air in. You'll see a wrinkle in the graft where the forceps is holding it. But as I increase the pressure of air in the eye, that will flatten out, and you can kind of push and release in the cornea to help it flatten out. I leave a tense airfill for about 5 to 8 minutes, and then I reduce the airfill to the size of the graft and dilate the pupil to avoid pupil block. And that's your dissect. Pretty straightforward. Not too many special maneuvers. You don't need to know cornea kung fu or the secrets of kung fu to get that done. But this is the real, I wouldn't say holy grail quite yet, but the definite winner in corneal transplants for endothelial disease. This is DMEK, Descemet's membrane endothelial keratoplasty. So only Descemet's endothelium in the central 8 to 9 millimeters of the cornea. This is technically difficult surgery. It has a steep learning curve. It has strict postoperative face-up positioning requirements, but the visual results are stunning. Often 20/20. Rejection rates are the absolute lowest with the lowest steroid load and the lowest steroid potency, and the recovery is the fastest. So this was a landmark study from Frank Price showing that the relative risk of immune rejection with DMEK compared to PK was 20 times less. For DMEK compared to DSEK was 15 times less. And it's important to note, this was done with the same center, with the same steroid dosing regimen in all groups, similar indications for surgery, a similar racial mix, same criteria for diagnosis of rejection. The 2-year cumulative rejection rate for DMEK is less than 1%. For DSEK, it was 12%, and for PK is 18%. This is no slouch surgeon. This is Frank Price. And so these numbers are correct. Indeed, when we'd see a rejection in a DMEK, we would call the fellows over and say, you might not see this again. Take a look. It doesn't look like a regular rejection with a rejection line. It looks like very diffuse, very fine PK here or there. That are they PK or are they just endopigment? That's rejection of DMEK. It's slow and smoldering and often asymptomatic. Another study out of the Price group showed that you don't have to use prednisolone for immune rejection prophylaxis. You can use fluoromethalone. They compared the two and they found out the rejection rate was no different, yet the rate of IOP elevation was greatly reduced with fluoromethalone. And if it didn't happen in the first couple of months of FML use, it tended not to happen at all, whereas with prednisolone, it could happen at any time. So here's a video doing DMEK. I've already stripped Descemet's membrane in the central cornea. I'm now injecting it. This is a 2.2 millimeter injector. I'm using the same incision I would use for phacoemulsification. This is a watertight injector. The whole point of DMEK is everything has to be watertight because this graft flows like water and it will follow water wherever it goes. I've made a little mistake here. I let the end of the rubber stopper come out of the end of the injector. I shouldn't have. Now it doesn't want to come back through my wound. You look at how soft this eye is. That's critical when you inject the DMEK, that the eye gets very soft, because if there's any pressure differential between the anterior chamber and the outside world, the graft will eject. So I immediately suture the wound. This looks like random motion of injecting fluid and getting lucky. Every maneuver I do here, be it pushing in the cornea, releasing fluid from the anterior chamber, putting fluid in, the amount and the direction is all a critical dance. I've got the graft kind of where I want it. I turn the light off and use a handheld slit beam to ensure the scrolls of that DMEK are rolling up at me, which means endothelium is facing the iris. And I secure the graft initially with a very small air bubble, that's about 0.1 cc's. And again, the dance of tap here, each maneuver is carefully thought out. It's almost reflex at this point. Can hardly explain why I'm doing it and why it works. But over 13 years of doing this, I figured it out. I get the graft unfolded, a quick couple of chip shots, golf strokes here, get the graft perfectly centered. And then once I'm centered and unfolded, now I'll place a large bubble in the eye. Every case gets an inferior iridotomy, and I leave them 90% airflow without dilating the pupil. As long as that inferior iridotomy has aqueous flowing through it, I won't get pupil block. So I'll fill it as far as I can, and then I'll go through the limbus to fill it the last 10%. I want to make sure they never lose light perception vision, and I want to make sure they're not going to go into pupil block. So I do watch them for about an hour or two in the PACU, just laying flat. Rarely do I have to let a little air out before they go home. Is it worth it? Is all that worth it? Best vision compared to any other transplant. Lowest immune rejection rate by a large margin. The only corneal transplant modality proven safe with low potency steroid regimens such as Lotemax or FML. No wound integrity concerns as you have with PK. No ocular surface disease. Minimal long-term infection risk. I can completely repeat it. If it fails, I can pull it out and put another one in. Best long-term corneal endothelial cell density for sure. Yes, I think it's worth it. Now let me show you a little bit different thing. This is a deep anterior keratoplasty. And if you use every piece of technology available to you, including a femtosecond laser, you can have some pretty amazing results. So Frank Price published this showing you could leave a little bit of uncut tissue with a femtosecond laser. Turns out the posterior side cut with a zigzag is the best. And Roger Steiner and Marjan Farid published this in 2009, showing it's easier to get a big bubble. And I did a review of patients who underwent femtosecond DALC with zigzag and then a toric IOL after they'd healed. Turns out that you can stop steroids in 1.5 and 3 months in most of these patients. You can take the sutures out by 6 to 8 months, and you can do a cataract surgery a month or two later, and they do quite well. Here's a guy with fungus under a LASIK flap that we were losing the battle on. This is his femtodalc an hour post-op. Looks just like a PK, but he maintained his own decimays. Here he is 6 months later, 20/20 uncorrect with a toric IOL. Why does this work? Look at the anterior and posterior section of this OCT of the cornea. The graft-host interface has no effect on the curvature of the cornea at all. It's perfectly smooth. And since we're using a zigzag pattern, the graft-host thickness disparity is absorbed in the zigzag pattern. This is a tree-fine DALC. So you can see the graft-host interface was straight and it makes a bulge and it causes irregularity in the corneal shape. This is a gentleman who had myopic keratomileusis, RK, epikeratofakia, PRK, and reasonably then ectasia. And this was before scleral lenses came out. This is the interface, graft-host interface of his DALC. You can see I did a very long femtosecond cut on the posterior there to make a shelf because his cornea was so thin that there was no way a graft would have fit. There had been a huge step off between the graft and the host, but with a zigzag, it absorbs the difference. And it's very smooth. 20/25 uncorrected with a toric IOL. This is a video quickly showing how this works. We don't have OCT guidance, so I have to do a bunch of ultrasonic pachymetry and then figure it all out by hand, how to program the laser. And then this is the FS200. So if you use this for LASIK flaps or whatnot, you know, it has a lot of suction. It really pushes hard in the patient's eye. And I can barely fit this zigzag incision between this corneal scar from high drops and the limbus. But you're going to see the cut starts. And the first thing I'm looking for is there any air bubbles in the anterior chamber? If there is, I've cut too deep. Okay, there's no air bubbles. We're cutting the first zigzag one way, and you're going to see it turn and cut the other way. And so I have about 70 to 100 microns of uncut stroma below my trephination with this laser. And then I do the same thing with the donor, about 250 microns bigger. So very close to same size on that. Then when we do, sorry about that, when we do the actual DALC, now I'm going to show you one for granular dystrophy. So this is what the patient looks like. He has a little bit too much haze. And so we've done the femto laser, we've done the donor. The donor still has endothelium just in case this doesn't work. I'll convert to a PK. I'll remove the anterior cap. I'll place a needle just to get my stromal tract going in the periphery where it's thicker. Now this is a different cannula it's the Fogler cannula. It's blunt with a little tip for air. When I get to the middle, I'll push air in there. This will separate Decimase from stroma, making a big bubble. Now I'll use a needle to inject viscoelastic into the big bubble without letting it collapse, so that when I take my knife to cut open the big bubble, I don't touch Decimase. There's a patent spatula to make sure that there's no adhesions between stroma and Decimase all the way out beyond the edges of my DALC incision from the laser. We can cut out the posterior stromal bed with Anwar scissors. We'll go all the way around. If you have not ensured that there is no adhesions here, you'll break Decimase and it's a disaster. But now, hold your breath. The only thing holding this eye together is Decimase and endothelium. It's not as stressful as an open sky technique, but look at that juicy cataract. I'm going to get that next. We're going to wash all the viscoelastic off. And now I'm going to take a mirror cell and I'm going to wipe Decimase right off. It just peels right off. I lay it in there, and now I have all the time in the world to sew it together. Normally we'd be rushing to get these first 4 cardinals in to close the eye and not have an open sky situation. I have all the time in the world to sew just right, get them perfect. We get the first 8 sutures in, you can start to look at astigmatism. And so I'm going to turn on a ring light. That kind of looks like an egg. Yep, not quite round. So I'm going to go ahead and adjust my astigmatism with the next 8 sutures. And you can see here when I finally get all 16 in and check the ring light, that's pretty darn good. Not a lot of astigmatism, just enough to use a toric lens, and it's regular. So that's important. So I'm going to skip through this. These are the results, but there's a lot of 20/20 planospheres in here. There's a few small misses, but the bottom line is femtodalc for corneal scars or irregularity is definitely the way to go if you're going to do a stromal replacement surgery. So conclusions, excellent results there. It's a small series that I've just shown you. I always under promise and over deliver. Future directions include things like 3D printed corneas or synthetic corneas. There's not enough data and use out there for me to comment too much on those, but I will tell you one thing. I think DESEC and DEMEC are going away within the next 5 to 10 years. I can't say too much about what I've seen overseas, but cultured endothelial cell injection for endothelial dysfunction is going to take over the world. You can get hundreds, if not thousands, of doses of cultured endothelial cells from one donor. You can culture them over many iterations and reduce their antigenicity, and you can just simply inject them into the anterior chamber and have them lay face down and send them home. Face down for an hour or two, send them home, and they clear up beautifully. So watch for that in the next 5 to 10 years. So went over a little bit. I apologize for that, but I'll yield the nil remainder of my time.
Thank you so much, Dr. McKee. That was a terrific talk. I really was very impressed, especially with the DALK. In the interest of time, I'm going to ask the members of it who are in attendance to ask you questions in the chat box, if that's okay, because we're about 10, 15 minutes behind right now. Not through your fault, this the whole afternoon. Could you please respond to questions about DWEC, Decimase membrane stripping without keratoplasty? That's one of the questions that was asked. Another question that was asked is, what laser do you use to make incisions for DALC, and can you use a conventional femtosecond laser for that? If you could answer those questions to the whole group on the chat box, that would be terrific. And I want to thank you again for your incredible experience and for sharing your incredible experience with us this afternoon. Thank you so much.
Thanks.
I'm going to give the podium back to Dr. Ed Lim, who will introduce our next speaker, Dr. Nisha Acharya.
Thank you, Vince. Our next speaker is Nisha Acharya, MD. She's going to talk about systemic therapy for uveitis, the risks and benefits of local versus systemic therapy, as well as treatment options for uveitic macular edema. Dr. Acharya is the Elizabeth Proctor Distinguished Professor of Ophthalmology, Epidemiology, and Biostatistics at UCSF and Director of the Uveitis and Ocular Inflammatory Disease Service at the Proctor Foundation. She's also the current president of the American Uveitis Society. Welcome, Dr. Acharya.
Thank you very much for having me. Let me just share my screen. I'd like to thank Dr. Hill, Dr. Lim, Dr. DeLuise. This looks like a really great meeting with a very good turnout. Does my screen show up okay?
Yes.
Yes, okay, great. Perfect. All right, so just move this out of the way. So yeah, so I'm a uveitis specialist at the University of California, San Francisco, at the Proctor Foundation. And I thought I would focus today on just some of the considerations when we think about local versus systemic therapy. I don't have any relevant disclosures. I do for my studies, I am getting drug donation from AbbVie for a clinical trial that's sponsored by the NIH. And many of the medications we use in uveitis are off-label. They're not approved by the FDA. So I just thought I'd start by, this is a patient that was referred to me, and this is very typical for my practice to get patients who've seen a number of other doctors. And here, there wasn't really a diagnostic dilemma. This woman had a diagnosis of birdshot chorioretinopathy, and I think we would all agree with that looking at the fundus photography. There's the ovoid kind of lesions in both eyes. But the question really was about how to manage her. She tried a lot of different things. And this was a few years ago, but I posted her case onto the American Uveitis Society listserv. We have a listserv where people, post cases or ask questions. And I asked, I kind of had a list of, okay, this is this patient. How would you all treat? I was just interested, to hear. I had my thoughts, but I wanted to know what others would do. And these are some of the responses. I'm not putting names, but I've quoted exactly, what people wrote. And somebody wrote, well, my patients often end up with 2 immunosuppressive agents, but uncommon to use anti-TNF, that's tumor necrosis factor alpha agents. Somebody else wrote, I am pretty quick to try to get to TNF alpha inhibitors now. And somebody else wrote, some would move anti-TNF earlier, but that's a matter of taste. And somebody else wrote, just bite the bullet and put in a Retistor implant, a steroid implant. So, same presentation you see of this patient, and you have so many different answers of what to do, and you get it. And somebody actually wrote this saying, good luck, no one knows. And so, this sort of illustrates that we do have a lot of options. It's not really, often there's not a set answer, but I think it's great to understand what our options are and how to think about what might be best for a patient and how to discuss them with them. So for this talk, I'll discuss some of the treatment considerations by anatomical subtype of uveitis and also some of the evidence supporting therapies, and then maybe just here and there throw in some case examples. Okay, so we'll start with anterior uveitis. This is a patient with hypopyon, acute anterior uveitis. This is classic of B27 associated disease, red hot eye. So anterior uveitis, is actually the vast majority of all uveitis. That's not the case in tertiary care centers like where I practice, where it's less than half of the patients have anterior uveitis because of the referral bias. But if you look out in the community and the reality of uveitis, it's thought that probably 70 to 80% of all uveitis is anterior. So it's really important to focus on how to treat anterior. And fortunately, most anterior uveitis cases are acute or recurrent, meaning that they have discrete episodes that are done, within a few months, and then patients are able to go periods of time, at least 3 months or more, without having inflammation off of all therapy. So for these kinds of situations, these types of anterior uveitis, topical corticosteroids are usually sufficient, fortunately. However, I think it's important to know that there are going to be patients that we all see where anterior uveitis may be chronic, where patients are not able to get off of therapy. And in some of those patients, I do think that long-term low-dose topical steroids may be acceptable. If patients understand the risks and the benefits, if they don't have glaucoma, they understand that there is some cataract risk, they can weigh that. If the low-dose steroids really do work to control their uveitis once or twice a day, many uveitis specialists will allow that chronically. However, there's going to be patients where that's not sufficient, and it is important to consider steroid-sparing therapy, immunomodulatory therapy, even for anterior uveitis in those chronic situations. I would like to talk specifically, though, about one type of anterior uveitis called juvenile idiopathic arthritis, or JIA-associated uveitis. It's the most common etiology of pediatric uveitis, and the joint and the eye inflammation are often not correlated with this condition. So many of the patients who have eye inflammation have very minimal joint inflammation, and the treatment may be driven by the uveitis in that case, if the joints aren't that involved. This is a very asymptomatic kind of uveitis with minimal or no conjunctival injection, but the inflammation may persist for years, We do think it burns out eventually where patients go into remission, but it's many, many years of inflammation depending on when patients first present. And so the problem with intermittent therapy for a chronic condition is that when you're having chronic inflammation, when you're sort of just intermittently going up and down on steroids, it's really hard to catch when the inflammation is. You're not getting a nice, even control of inflammation. You inevitably end up with chronic damage. This is one of the patients that I've seen who has, synechiae, still has pretty good vision in the right eye, but then the left eye has came in very late, unfortunately, but has band keratopathy, shallow chamber, pupillary membrane, cataract, very low vision and poor prognosis in this eye. The eyes are totally white. Even the right eye has a lot of inflammation going on, but we have a chance to save it. But this is really why we don't want just intermittent topical steroid therapy with a chronic condition. In 2019, so fairly recently, the American College of Rheumatology did update their guidelines for the treatment of JIA-associated uveitis. And they basically, the take-home message is they said that you really want to limit topical steroids. And one change from prior guidelines is they did say actually their guidelines are not to stay on any kind of chronic steroids and to escalate immunosuppressive therapy until you get off of topical steroids, and to start with methotrexate and to escalate to other biologics as needed. But their goal really was to keep on escalating therapy to get off of all steroids. So moving on to intermediate uveitis, this is a little bit of a mixed bag because there's such a wide range of severity. But basically, it's inflammation where you see inflammation in the vitreous, right? It's coming from the pars plana, but there's vit cells, sometimes also a little bit of anterior chamber cells, sometimes snowballs and snowbanks like in these photos. The treatment of this really depends on the severity and the chronicity. There are patients who will have a little bit of vit cells, but have excellent vision and no other sequelae of uveitis in their eye who don't need treatment. They could be observed, or they might need a little bit of treatment here and there. But on the flip side, there's also patients who have very severe, vitreous haze and vascular leakage and macular edema. So the treatment of this type of uveitis can range from steroid drops to intermittent steroid injections to sustained steroid implants to systemic immunomodulatory therapies. And the course can change over time. I've had patients who had kind of mild disease, and then for who knows what reason, they become much more severe and require more aggressive therapy to manage their inflammation. I do think it's really important, actually all uveitis patients, but especially intermediate posterior pan uveitis patients, but really anyone. It's true of anterior too for OCTs, because anyone can get macular edema, and intermediate posterior pan uveitis FAs as well. It's just so critical because we realize, I certainly, even I've been doing this for a really long time now, I don't think I can pick up macular edema when it's mild on exam. I think that the machine's better, than me when it's coming, when it's emerging, and it's better to detect it early. And so this is, of course, this is easily detected on OCT if we do it, but if we don't, we may miss. And then fluorescein is something that I think the field of uveitis is really learning to appreciate, that how important it is. And even in intermediate uveitis, where you don't see retinal choroidal lesions, we often will get them if you see obvious vessel changes or retinal choroidal lesions. But here, this patient, you see some vitreous, you see some snowballs here, and then there's maybe some changes around the vessels. There's not vit haze, but you can't really tell, right, what's going on. I wouldn't know for sure. There's cells, there's uveitis, there's intermediate uveitis. But when you do, and this is a wide field, but even, any fluorescein is helpful. You don't have to do wide field. You can see that, it looks okay early on, but as you go on, you start to see some fine capillary leakage, and this just increases in both eyes. And, we like to go for 5-6 minutes or longer in uveitis patients, but here there's tremendous fine capillary leakage and even macular edema and the nerves lighting up as well. So I would not have known, I did not know on exam that this person who has, 20/20 vision has this severe inflammation. And so topical steroids or a one-time injection of steroids that's short acting is not the greatest option when we have this kind of situation, right? Because, but I wouldn't have known if I hadn't checked the imaging. And same with the other eye. But one caveat about all uveitis, but this was a patient who had intermediate uveitis, just had vit cells did not have, and macular edema, and did not actually have any retinal or choroidal infiltrates. Here they do, but, and I don't have a photo because I didn't have this patient was referred in, and there were not photos beforehand, but, you know, really well-documented exams that it was just vit cells and macular edema, maybe 20/30, 20/40 vision, but comes into me with this, with basically really low vision, counting fingers, 2400, all of these whitish lesions in the retina, very poor perfusion. And it turns out this patient had bilateral intravitreal triamcinolone injections for macular edema in the setting of intermediate uveitis, and had syphilis, had undetected syphilis. RPR and treponemal antibodies were positive, actually both IgG and IgM. And so this was basically manifesting as, you know, the syphilis was evident. This kind of presentation with these whitish lesions is very classic of syphilis. They didn't have these before, though. They just had intermediate uveitis with macular edema. So just a reminder to all of us, and I always remind myself too, you know, always check the labs yourself, or make sure that you see the documentation that, you know, if you're going to, especially a steroid injection in the eye, because you can really blind somebody if you miss a syphilis injection, a syphilis infection. All right, and then finally, we'll move on to posterior and pan uveitis, which is where posterior is where you don't have really anterior chamber cells, but you have retinal choroidal inflammation, and often you have vitreous inflammation. Pan uveitis has inflammation in all parts of the eye. There's a number, these are just some, but there's many conditions that fall into the category of posterior pan uveitis that are chronic progressive. So conditions like birdshot, multifocal choroiditis, and with pan uveitis, or just multifocal choroiditis also. Behçet's with posterior segment involvement like vasculitis or pigeoness or relentless placoid, VKH, sympathetic, any kind of undifferentiated diffuse retinal vasculitis. And there's many more. But these conditions are known to be chronic and progress over time. They're not thought to be self-limited. And, you know, not to say that they never go into remission. Sometimes they do, but we just don't know when, and they often will go on for many, many years. So there's a long period of time in which the eyes can incur damage from inflammation. So I do think for these types of conditions, we do need to think about, you know, appropriate therapy. And so one of the questions we often get, or often very common referrals, is what about just repeated steroid injections in these patients with chronic or highly recurrent inflammation? So, you know, it may be acceptable for acute or very infrequent recurrent uveitis to treat with short-acting steroid injections, right? If somebody's just, you know, they have really infrequent episodes. But for all of these kinds of conditions that I just showed you, those are not intermittent type of diseases. Those are chronic progressive conditions. And so repeated steroid injections are suboptimal for these, because see, what happens is if you do short-acting injections like Ozurdex or dexamethasone, triamcinolone, any of those, they last for a few months and they work. The inflammation definitely goes down when you inject. But, you know, the thing is you can't predict when the inflammation is going to come back again. Sometimes it comes back right away. Sometimes you may go for a period of months and it comes back then, and we're usually not able to keep up and achieve a nice even immunosuppression with intermittent steroid injections. And each time the inflammation starts to increase in the eye, there is damage happening in the eye. And so over time, you have this concept of cumulative damage that's just, you know, causing, basically kind of accumulating in the eye, and that can be very, very consequential to patients in terms of vision, you know, especially if this is going on for many years. So that is the inherent issue, is the sawtooth pattern of inflammation with short-acting treatment. And I'll show you I have many examples from my clinic, but, you know, this is a kind of a serpiginous variant, like a relentless placoid kind of non-infectious, you know, uveitis, undifferentiated, there's no cause. But you can see this patient's had repeated episodes and they have a lot of scarring, including in the macula. It's very dangerous, right? When you get these things, if you can treat with steroid injections, but then when it wears off, you're at risk again. And so, you know, this patient, you can see on here, but then comes in with these new lesions, and they're right around the fovea here. These kinds of areas that are yellowish, they're new and scary, right? Because yes, you can treat again with steroid injections, but you know, there's just scars accumulating, and what if it hits the fovea? So that's why this kind of situation, I think you do want to have a long-term, long-acting treatment. You can see that these are new lesions clearly. So what are our long-term options when we have these kinds of chronic diseases? So there are local therapy options. So there's sustained release corticosteroids, and then there's also systemic immunomodulatory therapy. So I'll talk a little bit about them. So first, the systemic release corticosteroid implants, and some of these are not so long-term. Even Ozurdex or dexamethasone is considered an implant, even though it lasts 2 to 3 months. But these are the ones that are FDA approved for uveitis. So you have the fluocinolone acetonide or Retisert implant that has to be surgically implanted. It lasts about 2.5 years. You have dexamethasone injection. It's an implant technically, but it dissolves over about 2 to 3 months, called Ozurdex. Fluocinolone acetonide or YUTIQ, which is newer. It's about 3 years of therapy, but a much weaker dose of fluocinolone than the Retisert implant. And then finally, very recently, the suprachoroidal triamcinolone acetonide, which is also short acting. And the thought is maybe less pressure arises with the suprachoroidal injections, but again, a short acting therapy. And this is the patient that was getting short acting therapy, but you can see that the issue again is like, this is another type of serpiginous or relentless placoid picture, is that, and it's active down here in this whitish area, is that it's just dangerous if you're not able to maintain a long-term immunosuppression and doing short acting like Ozurdex injections. For this type of patient, it's very possible that you miss when a flare is, or you're chasing a flare and you're getting this, cumulative damage. You can see there's a lot of Ozurdexes in here floating around in the eye. And so, for this kind of situation, I don't think that's ideal as sole therapy. I think systemic therapy makes a lot of sense, or a longer acting steroid implant. This is another patient. This is a 35-year-old woman with vision loss in both eyes. You can see that it looks like there's fluid under the retina here. The nerves look a little bit hot here. And you can see there's just pinpoint leakages in both eyes and subretinal fluid. This patient actually had gotten just a steroid injection and then really didn't follow up by a provider. And what happened in the meantime is that this is VKH, right? It has pinpoint leakages, subretinal fluid. It was the right racial group. And this patient has also developed systemic findings of vitiligo. And so, with this kind of, again, another example of a condition that does need ongoing therapy. And in this case, I would say systemic therapy, because there's systemic consequences to this disease with vitiligo and meningismus and other stuff, tinnitus. Okay, and just to talk about a couple studies, the multi-center uveitis steroid treatment trial, or MUST trial, was an NIH-funded trial. I was involved in it. It wasn't my trial. I mean, I wasn't the PI. I was just a site participant in this, but I do think it's a very good trial in our field. It compared the fluocinolone acetonide implant to systemic therapy, all types, basically whatever systemic immunomodulatory therapy the doctor wanted to use. And it was for patients with active uveitis. The primary outcome was at 2 years. It was visual acuity. They looked at other outcomes as well, but there was also been 7-year outcomes reported now. And so at 2 years, the primary outcome endpoint, visual acuity was not significantly different between the patients who were randomized to the steroid implant versus systemic therapy. Implant predictably had much higher rates of cataract surgery and glaucoma, and there was higher rate of infections in the systemic therapy arm, but not a huge difference, but there was some. And so I think this was very predictable. But the vision, importantly, the vision was really not different, and patients did well, in both treatment groups. But at 7 years, interestingly, the systemic arm did better than the Retisert, the implant arm. They had about 7 letters better vision at 7 years. And so one thing that I wanted to highlight here is that what was interesting is that, so systemic therapy looked better at 7 years, right? And it was better for macular edema. It was better for vision and for everything, all the uveitis outcomes. The interesting part was in this trial, the Retisert implant lasts about 2.5 years, and it was not mandated that you repeat the implant. It was up to investigator discretion. And the median time to reimplantation was 5.3 years. Versus most patients stayed on the systemic therapy in that group. And so you're basically seeing what happens when the implant wears off and patients are not treated. It's a sort of kind of very interestingly showing us that uveitis chronic uveitis needs to be treated on an ongoing basis. And when you don't, or you kind of slip up with that, you start seeing consequence in terms of all of the outcomes. So I don't think it means that local therapy is bad. It just means that you need to keep up with it. And specifically with macular edema from the MUST trial, one interesting thing we learned is that for these patients with uveitis, that 40% of patients of uveitic macular edema is persistent at 2 years. And the breakdown for that is, of all the patients who had macular edema, about 71% of the eyes improved, and 60% of those actually resolved fully. But 11% improved, but didn't resolve. So they still had some persistent edema, and 29% didn't even meet the definition of improvement, which is a 20% decrease of macular thickness. And so together, that's 40% of patients who still have ongoing issues with macular edema. So I wanted to just bring that up because in uveitis, macular edema is often a chronic issue that we have to keep on treating. It's not like a one and done, inject and you're done. It often requires ongoing management, and it's just the reality of having macular edema in the setting of uveitis. So a really big problem, it's the #1 cause of vision loss in our patients is uveitic macular edema. Current standard of care is steroid injections, and the POINT trial, which I was involved with, it's an NIH-funded trial that was run out of Hopkins, did show that intravitreal triamcinolone and dexamethasone implant, which is Ozurdex, were superior to periocular. So we do think that putting steroid in the eye is better than periocular. However, there's the known side effects, right, of pressure, rise, and cataract, which we accept with these therapies. As of now, we don't have any approved or standardly used non-corticosteroid injectable therapies. Sometimes people use anti-VEGF or intravitreal methotrexate off-label, but there's not strong evidence to support those. So that's an unmet need. And then finally, for systemic therapies, I'm not going to go into like all the details of them, but I want to highlight that steroids are still really important in our care. But the goal is to use them to get inflammation under control and then to hopefully just like taper and discontinue. But at the very least, to get down to at least 7.5 milligrams daily or less of prednisone is considered a medically acceptable or desirable dose. Tons of side effects. I'm sure everybody knows this with steroids. Unfortunately, that's the limiting factor. And so that is why we don't want patients to stay on them. And that's why we look at other drugs. So we have the so-called conventional immunomodulatory drugs or disease-modifying anti-rheumatic drugs, DMARDs as they're known. And there's lots of classes. Basically what's happened though over the last 5-10 years, really 5 to 10 years, is that now we're almost always just using anti-metabolites like methotrexate, mycophenolate, and maybe azathioprine. When we start when we want to start immunosuppressive therapy, we are rarely these days using T-cell inhibitors or alkylating agents. Sometimes we will, but generally if we fail getting steroid-sparing control with an anti-metabolite, we move on to biologic therapy nowadays because they're available. I'm going to just maybe try to move forward a little bit here, but these conventional agents are not perfect. So data from retrospective studies show that they're about 50 to 60% effective in achieving steroid-sparing control of uveitis. So I think it's important to tell our patients, these drugs have been used, they're all off-label, they're not FDA approved, but their safety profile is well established. They've been around for many decades. They're not perfect. It's a chance that you might have to try one or two and still they may not work and you may have to move on. I led a trial that was called the FAST trial, the First Line Anti-Metabolites of Steroid-Sparing Treatment trial. It was an NIH-funded trial. We did a direct comparison of methotrexate to mycophenolate mofetil as starting line therapy for patients who needed to start immunosuppressive therapy who had active inflammation. And it was really, we enrolled internationally. And kind of to summarize, our primary paper does have the main results, but basically, we found that there was not a significant difference between methotrexate and mycophenolate, although methotrexate had about 10% higher treatment success of steroid-sparing control compared to mycophenolate. So 67% versus 57% with mycophenolate, but the p-value was 0.2. And there was some signal that methotrexate might have been better for posterior panuveitis. The p-value was significant, but it is, a subgroup analysis. So, and the adverse events were overall pretty low. There were more liver function test abnormalities in methotrexate, but pretty low numbers, 13% versus 7% with mycophenolate. So in summary, for the FAST trial, either drug I think is fine. We didn't find evidence that mycophenolate is superior. Methotrexate is a once-a-week drug and has a pretty good safety profile. So I do think it's a decent first-line agent. I didn't show you the data, but even in our trial, just like the MUST trial, macular edema was often persistent. And so the point is with systemic therapy, I think we're unfortunately still requiring additional therapy. Macular edema often is not going to completely go away, no matter what systemic therapy we're using. And then finally, getting to biologics, I think this is the future. You know, it's exciting. These are therapeutic agents that are really have specific targets in our immune system. We only have one of these approved for uveitis, which is adalimumab or Humira, but we use all of these off-label. And, you know, we use them in patients where they don't really respond to other therapies. At least we have them now, so it's exciting. But I'll just mention adalimumab because we can prescribe it, you know, and get it covered by insurance for intermediate posterior panuveitis. And it's also been approved for tons of different autoimmune diseases. So it's an injectable drug that patients can give at home. It comes in a pen or a prefilled syringe, but pens are easy, every 2 weeks. And, you know, it's pretty well tolerated, actually. There are side effects with any immunosuppressive therapy, including risk of infection, but overall, the risks are actually pretty low. I want to just mention one thing with TNF-alpha inhibitors specific to uveitis is that if you're starting it in a patient with intermediate uveitis, we do need to neuroimage them with getting a brain MRI. And the reason is that intermediate uveitis can be associated with multiple sclerosis. And TNF-alpha inhibitors can really make multiple sclerosis worse and cause pretty bad demyelination. And there are patients who might not have MS symptoms or signs. If you do, you should obviously image them, right? But even if you don't, you could have undetected disease. So we do get a brain MRI if we're going to start anti-TNF therapy in patients with intermediate uveitis, even if they don't have signs of MS, because we don't want to cause them harm. And these are signs of, you can see these little white matter periventricular lesions here. I'll skip this. This drug has gone through trials, and they're published in New England Journal and Lancet. Really strong evidence that Humira, the adalimumab, that works well for uveitis. And the other thing is, it seems to be very good, TNF-alpha inhibitors, and including adalimumab for retinal vasculitis. You can see here one of my patients with this, and then it went away completely with that drug. And there's a white paper published in Ophthalmology saying that for Behçet's, disease, which that often has vasculitis, that really the recommendation is anti-TNF necrosis factors and not traditional immunosuppressive therapies anymore. So we always use steroids, but we move quickly to TNF-alpha inhibitors for this disease now. But just to finish up, one of my patients, I use a lot of TNF-alpha inhibitors. You got to always be vigilant. And so this patient showed me on the skin that he has this patch here. And even though his eyes were doing great with Behçet's on adalimumab, I didn't know what this was. I sent him to derm. It was biopsied, and it was coccidiomycosis infection on the skin. And he also had it in his lungs. And so it's a fungal infection. And this is, these drugs do have, they do affect the immune system, and you have higher risk of some of these opportunistic infections. And so it's something we have to always monitor our patients for. So in summary, I think the key point is that for chronic uveitis, it's the recognition of when uveitis is chronic. We do need some form of sustained immunosuppression. Usually we'll do a stepladder approach, where we'll start with steroids and then traditional conventional therapy and go up to biologics. But sometimes we'll use biologics early, and we can, with adalimumab because it's approved. Short-acting local therapy, I think, is good if you have a disease that's acute or, rarely recurrent. It's not great in chronic uveitis. And always make sure you rule out infection, really in all patients with uveitis, but especially before you inject steroids. I do think macular edema often requires adjunctive local therapy because it's not going to always go away, and it often requires recurrent therapy. And just treatment needs may change over time. So we always have to kind of think about what's working for our patient, what's not, and continuously reevaluate. I want to just acknowledge for the studies that we've done. National Eye Institute's funded them. And just want to thank all my colleagues at Proctor and all the patients who participated in all of these studies that we've done, and just my own patients. I keep on learning from them, and it stimulates our questions that we like to answer. It's all very practically oriented. They drive all of the research. So with that, I'll conclude, and I'm happy to answer your questions in the chat or verbally or
Thank-
however would be best. Thank you.
Thank you, Dr. Chadia. It's very, for most of us, very difficult patients, kind of scary to handle, as you very nicely pointed out. You see these vision-threatening scars as they're approaching the fovea, and it's a very uncomfortable feeling. So your talk was appropriate and excellent, and really appreciate your time. And I'd like to thank our speakers for giving us their time and experience so that we can continue to serve our patients with excellence. Would encourage you to join us for tomorrow's meeting. We'll be covering topics on telemedicine, 3D OCT, allergies, cannabis, and we'll honor Joan Miller, who will give the HERPS lecture on treatments for early and intermediate AMD. As you can see on the screen in front of you, we put the QR code back up so that you can use that to take you directly to the website. Click on the current meetings and do the questions and the assessments so that you can get your CME credits. And if you want to see tomorrow's agenda for the meeting, the QR code is there also. So thank you all for spending your evening with us. We look forward to seeing you tomorrow. And our next meeting will be on June 9th. So we'll see you at that live meeting where there'll be lunch, vendors, and your colleagues. Thank you and have a good evening.